scrotal swelling, and other one will be breast mass. So the first one will be a scrotal swelling case from Vaidya Institute of Medical Science. Dr. Rohit Rebello, the exam going candidate, will be the presenter. And the examiner panel for this case will be myself, Dr. Shashidhar, then Dr. Amit sir from TMH, Dr. Leenu from Kidwa, and Dr. Venkat from Adyar. So the exam going candidate will be the presenter. And the examiner panel for this case will be myself. Can you hear me, Vinayak? Hello?
I can hear you, sir.
Okay. So I think we can start, I think, actually.
Okay, go ahead, sir. I think...
Rohit?
Yes, sir.
Yeah,
good morning. Am I clear, sir?
Yes. Audible.
Okay. Good morning, everybody. Today's first case will be testicular swelling. 26-year-old male by the name of Shamsha, hailing from West Bengal, a farmer by occupation, came with chief complaints of generalized pain in the upper abdomen for the last 5 months, loss of weight and loss of appetite for the last 3 months, breathing difficulty along with cough. Patient had complaints of pain in the right upper abdomen about 5 months back. The pain was dull aching in nature, and the pain was aggravated post. The pain was aggravated post-meal and relieved on rest and medication. There was no complaint of referred pain. The patient's pain aggravation has increased over the period of the last 5 months, and now it is not relieved with medication since the last 1 month. Patient also has complaints of severe weight loss because of aggravation of the pain on oral consumption of food. The weight loss is not quantifiable. Patient then developed complaints of breathlessness that initially started to bother him during his work activities, which was about 3 months back. The patient has patient's complaints of breathlessness has gradually progressed, and now he has to take a rest after walking for about 100 meters. This progression has happened over a period of 2 months, and the patient does not have any relief with any medications at present. The breathlessness was also associated with cough. The cough was dry in nature with very minimal expectoration. Cough was aggravated on working and relieved on rest. The patient also noticed a swelling in the right scrotum, which has gradually increased over a period of last 1 month. The swelling in the scrotum was noticed by the patient while he was having bath. And as he symptomatically started develop symptoms of cough and expectoration as well as abdominal pain increased, he comorbidities like diabetes, mellitus, bronchial asthma, epilepsy, tuberculosis, hypertension. There is no history of any previous surgeries in the past. Personal diet consumes mixed, personal history consumes mixed diet. There's no history of cannabis use. There's no history of oral tobacco. There is history of oral tobacco use with gutka for the last 6 years. There is no history of any alcohol intake. Bowel and bladder habits are normal. Family history, there's no history of any malignancy in the family in the first and second degree relatives. He has one elder brother, one younger sister. He's married and has 2 children. Treatment history, he came to our institute with similar complaints as he was referred to a higher center when he went to a local doctor. And now on examination, he is his performance status is 1, his pulse rate is 80. His
maybe you can summarize the history before going ahead with the examination.
Yes, sir. 26-year-old male, Shamsha Alam, came with complaints of generalized pain in the upper abdomen for the last 5 months, loss of weight and loss of appetite for the last 3 months, breathing difficulty associated with cough without expectoration for the last 2 months, and a swelling in the right testis for the last 1 month without any significant past history, with the history of oral tobacco intake, no significant family history.
Yeah, so what do you think from the history?
from the history, I would like to, considering the age of the patient and the fact that he has noticed a swelling in the right testis, my first differential diagnosis would be a malignancy of the testis, probably a germ cell tumor of the testis. I would also like to keep a differential of lymphoma because he has right upper abdominal pain and also would and cough, and also would like to keep another differential of rhabdomyosarcoma.
Okay. Why rhabdomyosarcoma?
Paratesticular rhabdomyosarcoma could also present with a testicular swelling, and probably that right upper abdominal pain could represent liver metastasis. Probably the the symptoms of cough and breathlessness could probably represent lung metastasis.
What is the age group of rhabdomyosarcoma?
Rhabdomyosarcoma is usually found in a younger age group, but alveolar variant of rhabdomyosarcoma can be seen in the 20s.
Okay.
Why did you say lymphoma?
One thing is that right upper quadrant swelling is, it's very unusual for a germ cell tumor to have that, sir. So that is why one feature, one lymphoma would be one differential. And even it could explain the test findings also. With extra.
How common is lymphoma going to testis?
Lymphoma going to testis is less than 5%.
So you're thinking about primary testicular lymphoma or generalized lymphoma going to testis in this case?
Primary testicular lymphoma is more common in age group above 50, and most common above 60 years of age. I'm thinking of a DLBCL probably in the abdomen somewhere that has probably with extranodal spread to probably the liver, and maybe a testicular. Although that would be last to my differential diagnosis, but it is still a possibility.
What about the possibility of a primary GI malignancy with metastasis to the testis? Because this patient had initially right upper quadrant pain, loss of appetite, loss of weight, then developed breathlessness as well as cough, maybe dry cough, and then noticed the swelling in the testis.
Yes, sir. Colonic, but he does not have any bowel and bladder habits were normal, sir. He does not have any symptoms of what.
Need not always.
Yes, sir. So a GI malignancy, a colorectal malignancy definitely is possible. It can explain the chest findings as well as the right upper quadrant swelling. Pain. Sorry.
What other point will you argue against? Of course, there are no symptoms related to the GI tract, but that can always happen. Many times, many of the cancers, the colorectal cancers are many times silent. But what is the other point which you would like to? You can definitely consider, but what I'm telling is that what is the other point which is against?
One thing is there's no family history, sir. Usually patients who present with GI malignancies at this age would have some sort of a
what I wanted is that you should have told age. Of course, you can have young colorectal cancers also, but in general, when we tell about carcinomas, that is usually in the older age group.
Yes, sir.
Yeah.
Can I ask, sir?
Yes, sir. Yes.
Yeah. So what is the other important point in history when you are suspecting a testicular cancer? What are the initial point what we want in a testicular cancer? I think when we start with a testicular, you have to say whether it's a married or unmarried, because that will have and as a family, that is also an important thing. So I think if you're suspecting, you have to say this married and family completed. Have you mentioned?
Yes, sir. He has 2 children, sir. He's married. I mentioned the three of the family charts.
Okay.
Why it is important, Dr. Rohit?
Actually, testicular malignancies, about 50% of them present with oligospermia and about 10% of them present with azoospermia. And in the genesis of testicular malignancies, hypogonadism is one of the things that could actually lead to a testicular malignancy. So
what are the implications? What are the implications? Suppose he is unmarried.
I would, if at all, after I worked up the patient and have proven that this is a testicular malignancy, and I would, after staging the patient, I would like to give him either chemotherapy or radiotherapy. I would like to consider him for sperm banking, so because the chemotherapy and radiotherapy both can cause.
Right.
What are the risk factors for
on examination?
1 second.
Yes, Dr. Venkat.
What are the risk factors for developing germ cell tumors?
One thing is patients who have previous history of infertility are at a higher risk of developing germ cell tumors. Then marijuana.
Is it so?
Yes, sir.
What
Their
is the
relative risk
most
is high.
common?
Is the
Cryptopsides.
history of infertility a risk for germ cell tumor? I'm not aware of it. Other examiners can please clarify.
Most common risk factor. What do you think?
Is undescended testis.
Yes.
Yes.
Yeah, first tell common things.
Common things.
Okay.
Herpesism, undescended testis is one you should tell first.
Then,
Which type of tumor is common in undescended? Which is more common? Which variant? Hello. Yes, seminoma is more common in the undescended testis. And the other risk factor, which I think at least one or two, infertility. So the incidence of infertility is too high. So so it may be sometime it's not a per se the cause factor. Sometimes some patient on workup they might turn out to be this. So to level it as one of the predisposing factor, I think it's a little bit difficult to say. But definitely the patient who have a testicular cancer have a coincidental infertility. So whether this one is the cause or that one is the region, it's difficult to predict.
yes, I agree with Amit. Infertility, I won't put it as a cause for testicular cancer.
It's very common.
Yeah, it's very common. Yes. What else? Some other very common things. Which
Family
syndromes?
history.
No. Okay, more than family. What syndromes are associated?
Klinefelter syndrome.
What are those? What are these syndromes called as? What is the term?
Particular term for that? It is started with testi.
Dysgenetic syndromes, no?
Testicular dysgenesis syndromes.
Yeah. So I have a question to you.
Yes.
Turner syndrome is also a testicular. It's an ovarian dysgenetic genetic syndrome. Okay,
Yes.
Turner syndrome. But Turner syndrome patients do not develop ovarian germ cell tumors. Okay, so not all testicular dysgenetic syndromes develop, germ cell tumors. Why? It's a gold medal question.
I'm not sure.
I'll tell you the reason why. You need the dysgenetic X chromosome to be there to have a germ cell tumor. Turner's doesn't have an X, it's only XO that is absent of, Y chromosome, not X. X chromosome is there, there's no Y chromosome. So presence of studies have shown that you need to have a Y chromosome in dysgenetic syndrome to develop germ cell tumors. You can continue.
Okay. So on examination, performance status is 1. Pulse rate is 80. Blood pressure is 110 by 70 millimeter mercury. Right arm. There's no pallor, no icterus, no cyanosis, no clumping, and no palpable lymphadenopathy. Higher mental functions are normal and patient is oriented to time, place, and person. On local examination, the patient has on per abdominal examination, all quadrants appear to move equally with respiration, and on palpation of the abdomen, an enlarged liver is seen, with which has a sharp margin, smooth borders, which is present 5 centimeter below the right caution.
Can
margin.
I interrupt in between?
Palpable. Yes.
Have you done the journal examination? Have you told the journal examination?
Yes, sir.
So what important
yes, sir. No
finding?
pallor, cyanosis, clumping.
Other thing, these are the MBBS student will tell. So what are the important thing which rarely we see in a testicular patient presenting with the in general examination? Which specific test? So why the testicular cancer patient will develop cyanosis? Have you seen any patient developing cyanosis or clubbing? I have not seen in 12 years.
Basically, you have to look for. No, sir. Basically, you have to look for gynecomastia.
Yes, so that is important. So that may give a clue that the CG tumor secreting tumor may have this thing. So I think in examination, try to be more specific for those at least finding which are more relevant to that tumor. So cyanosis, clubbing, icterus is very, very rare. It's a very, very advanced stage. How commonly we see a testicular presenting with icterus? Very, very, very rare. So I think you can just conclude that, but the common thing is the examiner wants to hear in that thing.
Did you mention gynecomastia or you didn't mention?
I think he missed.
Yeah, continuing with
Continue.
Amit's question, I think you should tell what are the important general physical examination findings you will
No, sir.
specifically look for in a suspected case of germ cell tumor. So one, you have already mentioned gynecomastia. What other specific general examination findings will you look for in a patient of suspected germ cell tumor?
Supraclavicular lymphadenopathy.
Okay. So that you have already told, no pallor, cyanosis, jaundice, clubbing, edema,
And
that already told. Other than that, specific general examination findings which you will look for in a patient of suspected germ cell tumor.
Any
Some of them we have
dysfunction
already
that might be
discussed in the
present.
history. So many of those things probably
See,
when you discuss the risk factors also we discuss many of those things.
syndromes associated with germ cell tumor and their manifestations, or what are the etiological factors in which you can get the clinical general physical examination findings?
Yes.
Yeah, basically, we have to rule out those testicular dysgenesis syndromes like Klinefelter syndrome and.
Correct. So, what are those general physical findings which you will come across in such cases?
They'll have polydactyly, sir. They'll
We
have.
discussed Klinefelter syndrome, so you can tell some of the findings which you will have in Klinefelter syndrome, which you will specifically look for. So, Klinefelter syndrome many a times may not be very obvious. You have to specifically look for. It will go many a times undetected until and unless you specifically look for those features. Or you want to tell anything about the stature? You want to tell anything about the body hair?
They will be short stature, sir.
Short stature.
Pardon?
I think it's wrong. It's short stature. I think it's.
I'm not sure about this.
So better to say that I'm. So if you don't know the exact answer, better to say I'm not sure rather than telling a wrong answer. So it's better. That's a good practice.
Yes.
Okay. Anyway, I think we will continue. So
Yes,
we'll not stop with that. You can go and make a list of the general examination finding because this will be definitely asked in the exam. And just one more thing is that you mentioned about Klinefelter syndrome and even Dr. Venkat discussed about Turner's also. Which are the other two genetic, any other genetic abnormalities where you get GCTs at an increased frequency other than Klinefelter's?
One is these patients who have isochromosome 12p mutations, they tend to have increased risk of testicular germ cell.
No, other syndromes like Klinefelter syndrome, anything else, any other genetic abnormalities or genetic syndromes where you get increased frequency. I think one was already mentioned, other than Klinefelter's also.
This I'm not sure of.
Okay, fine. We'll go ahead.
Okay. On palpation, no other palpable masses are found in the abdomen. The right testis measures about 6 into 6 centimeters. It is larger than the left testis, which measures about 3 into 4 centimeters. The right testis appears hard and irregular on palpation, and there is absence of testicular sensation on palpation of the right testis, and testicular sensation is present over the left testis. There is no, the spermatic cord is palpable. It is possible to get over the swelling. There is no presence of any scar over the scrotum. There is no presence of any scar in the inguinal region. There are no palpable inguinal lymph nodes. On respiratory system examination, there was no, the normal vesicular breath sounds were heard and there were no added sounds. On cardiovascular system examination, S1, S2 heard, there were no murmurs heard. On CNS examination, high mental functions are normal, motor and sensory system are grossly normal.
You spoke about absence of testicular sensation. So
yes,
what is the relevance of this? Because some examiners would consider it as human right violation squeezing somebody's testis. It's not a pleasant sensation. So how is it going to help your case or your diagnosis or your management by squeezing somebody's testis to see whether it's got testicular sensation or not?
Actually, it would go more in favor. If it's a painless testicular swelling and there is absence of testicular sensation, the differential diagnosis is very short, sir, one of which is malignancy, and the other thing is advanced stages of leprosy.
Well, what is the other? So somebody's got a testicular swelling with pain. That is when non-squeezing. What is your differential diagnosis?
Then it could be a testicular swelling with pain, sir.
What?
It could be a torsion of the testis. It could be an infection, sir.
Yeah,
It
you
could
don't
be
need to. You don't need to squeeze these testes for torsion.
Yes, sir.
Infection will have signs of inflammation. I'm just telling you, some people, and some books also mention that it is not ethical to. It's painful squeezing somebody's testes.
So, do you want to say that all testicular cancer present with painless swelling?
No, sir.
How common? How common or uncommon?
Can present as painless, sir.
Painful.
Painful is
How many present with painful testicular swelling?
20%. Mostly are painless. You may see about 20% only.
Okay, carry on. Sorry, it's just something I keep on thinking. It's easy to mention there is no tenderness on palpation. You know what? You can touch the testes, but I would squeeze the testes just to see if there is any pain or not. Yeah.
Next, I would like to do a complete hemogram, liver function test, renal function test, and the LDH, AFP, and beta HCG. And based on these results, I would like to proceed further.
So did you give a final diagnosis after your examination? What is your differential diagnosis, or summarize your findings? You're directly gone to investigations.
Right now, the differential, right now it goes more in favor of a testicular malignancy, probably with the liver metastasis. And although there are no signs of any lesion, any lung metastasis, symptom-wise, there could be either a node in the mediastinum or probably some lung metastasis might be present. So that would still be my diagnosis. I've not found any nodes in the supraclavicular axillary or any other area. So lymphoma usually would have had some nodes present there. Paratesticular RMS usually presents as a mass above the testis.
You're not supposed to teach us. You have to tell us what is your conclusion after my history and examination. I find my probable differential diagnosis is germ tumor of which side, which testis?
Right side.
Online case presentation అవుతుంది national level లో.
Hello. Yeah, I just lost connection. So what is ultimately you're finding? There is a hepatomegaly and there is a right testicular swelling. Is it?
Yes.
Yes, Dr. Lino, I just asked him to summarize and give a diagnosis before proceeding to investigate.
No, I just wanted to know whether there was any other mass palpable other than the liver and the right the testicular swelling.
No, sir. There were no inguinal nodes. There were no palpable nodes anywhere else in the body, and there were no chest findings. Only hepatomegaly with right testicular swelling.
Okay.
Summarize.
26-year-old male by name Shamsha Alam came with complaints of generalized pain in the upper abdomen for the last 5 months, with loss of weight and appetite for the last 3 months, breathing difficulty for the last 2 months, and swelling in the right scrotum for the last 1 month, with no significant family, personal, or past history, and with hepatomegaly 5 centimeters below the right coastal margin, and a right testicular and the presence of a right testicular swelling with no other significant findings.
So do you think that germ cell tumor of the testis will go to the liver without going into the retroperitoneum?
No, sir.
Any germ cell tumor, any type which can metastasize in that way?
Choriocarcinoma.
Okay, so which are the germ cell tumor types which will metastasize hematogenously?
Choriocarcinoma is the one that metastasizes hematogenesis.
And anything else?
Second one. But do you think that choriocarcinoma will have that protected course for 6 months? Has a 6-month history?
No, sir.
So then, what the Leo sir was asking, second pathological variant which can have a hematogenous spread and can present with this time duration period.
Yolk sac tumor, sir.
No, it's embryonal. Embryonal have a more chances of hematogenous spread than the yolk sac. So how you like to produce? So suppose the tumor markers are elevated. Suppose the beta HCG say in this patient for that duration maybe 10 lakh, 15 lakh, and a AFP of say 5,000. So how you like to produce with the beta HCG value of 15 lakh and AFP of 5,000 and LDH, and rest parameters are more or less okay.
So initially, I would like to do imaging, sir. So I would like to do a CT scan of the abdomen, pelvis, and thorax. And with very highly elevated beta HCG, I would also like to do an MRI of the brain. Because choriocarcinoma is still a consideration that I have to keep, and it is known to have brain metastasis. Then after that, I would like to do serology and then proceed with the high inguinal orchidectomy if the patient is not in crisis at present.
So you would like to go ahead with the first with the orchidectomy.
Imaging, sir.
Imaging you have done, and now find the liver is have a 3 or 4 metastatic lesion of 3 centimeter with multiple pulmonary metastasis.
I mean, if the patient is not in crisis, we can go in the orchidectomy, sir. But there is no requirement.
So when you exam, you have to say, you don't say orchidectomy, but you have to name the
high inguinal orchidectomy.
Yes, you have to be precise. So why scrotal orchidectomy? Why not a scrotal orchidectomy? Why we do not prefer?
Scrotal orchid, basically the testis develops from the mesonephros, so it arises from the and is supplied by the direct branch of the aorta. Because of that, the lymphatic drainage is into the interaortic cava or the para-aortic lymph nodes. By going into the scrotum, we are actually there's a chance of seeding it into the inguinal lymph nodes, because the lymphatic drainage of the scrotum is from the ectoderm. So that is the reason you have to do a high inguinal orchidectomy and not a scrotal orchidectomy.
Why not low? What is the difference between high and low? Why it is called as high?
High inguinal orchidectomy is done where the incision is actually made at the superficial at the deep inguinal ring. The reason for that is when you need to actually proceed ahead, when you need to do retroperitoneal lymph node dissection, the entry point remains the same.
What is Shivasu's procedure? Any idea?
Shivasu's procedure is in patients with testicular germ cell neoplasias. You put a high inguinal orchidectomy incision. You pull out the testis, you do a biopsy, send it for frozen section, and if it comes positive, you go ahead with doing an orchidectomy. If it comes negative, you actually put the testis back inside.
So coming back to the scenario which Dr. Amit told, that this particular patient is having liver metastasis, probably multiple pulmonary metastasis. The patient is very much symptomatic. You told already cough and dyspnea on exertion and a beta HCG of more than 1 lakh. Would you like to do any orchidectomy upfront to confirm the diagnosis?
No, sir. As sir said, because there is a dual marker elevation, both AFP and beta HCG are elevated, I do not require to do a orchidectomy to confirm the diagnosis. I can start off the patient on chemotherapy upfront, and then probably after 2 cycles, when the do an orchidectomy. But however, if the patient is not currently in crisis, then I can go ahead with an orchidectomy.
Also, what is choriocarcinoma syndrome? So that satisfies, correct? No, a beta HCG of more than 1 lakh with pulmonary as well as non-pulmonary visceral metastasis. So those are the patients. So that satisfies for the choriocarcinoma syndrome. And in such a scenario, definitely there is no question of doing an inguinal orchidectomy upfront. So that is an indication more than 1 lakh beta HCG, and with this picture with testicular swelling and liver metastasis and lung metastasis, what more you are required? So those patients that should be treated as a medical emergency. No question of going in for an orchidectomy.
Even
just one more question regarding the scrotal versus inguinal orchidectomy. So do you think that if a patient undergoes scrotal orchidectomy rather than an inguinal orchidectomy, the prognosis is altered, or the patient is going to have a bad prognosis as compared to somebody who has undergone an inguinal orchidectomy?
No, sir. The prognosis does not vary. The chance of local regional recurrence in a patient who is going to receive chemotherapy after a scrotal orchidectomy is between 0.3 to 3%.
So then why should you do an inguinal orchidectomy?
Because that one thing is later on when you want to do a retroperitoneal lymph node dissection that
Yeah,
will
that you
travel-
told that you would subsequently would like to remove the remaining stump of the spermatic cord. So usually to identify that stump, what do they do at the time of inguinal orchidectomy?
A special procedure they do. So how they will identify?
I'm not sure.
So the spermatic cord is ligated in a particular way and with a particular material so as to identify subsequently. Okay, so you can ask your surgical colleagues regarding that. And the other, I think already you discussed. So if there is no difference in scrotal versus inguinal orchidectomy in the ultimate outcome and the prognosis, then why you should do inguinal orchidectomy? So one, you told that, one is that you would like to remove as much of spermatic cord as possible. And the other thing is that subsequently, if the patient has to undergo retroperitoneal lymph node dissection, the remainder of the spinal, the spermatic cord can be removed. Spermatic cord involvement, does it alter the prognosis?
Yes, yes. Spermatic cord involvement does alter the prognosis.
Okay, so what types of spermatic cord involvement you can have in GCT? What are the types of, according to the AJCC 8, what is the difference in the spermatic cord involvement? Are there different types of spermatic cord involvement?
I'm not sure of this.
Yeah, so just go and see if the spermatic cord involvement is direct, and if it is discontinuous, does it alter the prognosis and does it alter the stage?
Okay.
So how you will start with this which chemotherapy and what are the precautions you will take in this case?
This patient has completed his family, so I would like to ask him if he is interested in having more children. If he is, then I would like to get his sperm count done because he. Yeah.
And management, come to the management.
So okay, so basically the things I would like to look at the burden of metastasis in the lungs.
So I already told you it's a high volume, multiple liver metastasis, multiple pulmonary metastasis. All these are there with you.
Okay. So then I would prefer to use chemotherapy like VIPs rather than BEP.
So you want to go ahead with first cycle of VIP in this patient immediately?
If it is a no, I mean.
So we discussed already about the choriocarcinoma syndrome. So once you have a patient of a choriocarcinoma syndrome, how differently will you manage that patient from your regular germ cell tumor patients?
Initially, you need to give something like a prephase.
What prephase?
With etoposide and platinum.
So what are these patients at risk for?
One thing, they're at risk of hemorrhage.
Where?
Usually, if he has lung metastasis, he'll be at risk for hemorrhage in the lungs. If he has brain metastasis,
they are at risk for pulmonary hemorrhage and they are at risk for hypoxia. So these patients should be ideally put in the ICU. And as I told, they should be treated as a medical emergency. So how will you reduce the chances of pulmonary hemorrhage?
By starting off with low dose chemotherapy.
What is that low dose chemotherapy?
With cisplatin and etoposide.
Be specific. Yeah.
I think what Dr. that is another request for. So whenever in exam, be specific. What chemotherapy? So best to say the regime rather than I will like to give chemotherapy. So don't say chemotherapy. I would like to give this chemotherapy, preferably with this dosage. So the examiner knows that you are sure that you are. So don't wait for examiner to ask which chemotherapy, cisplatin, etoposide, what dose is special. Best to be more specific regarding the I will like to go ahead with cisplatin, etoposide for this dose for this time period. I think that what Dr. Neelu wants to with you, that be specific.
So at 50% dose, I would like to start cisplatin and etoposides.
5 days?
No, 3 days.
Okay. And what are the other complications can you expect in this patient apart from the pulmonary hemorrhage and the what other things you would like to see simultaneously while giving chemotherapy?
Tumor lysis syndrome is one possibility, sir.
Yes.
So I would like to monitor the renal function test, electrolytes, and uric acid.
So you told me why you want to give VIP. Any specific reason for this? Why you want to go ahead with VIP?
have extensive lung involvement, sir. Bleomycin is known to cause the chances of getting bleomycin-induced lung toxicities are higher. And
Higher? How frequent is the bleomycin? How commonly we see bleomycin, or whether literature quotes about the bleomycin, and what are the risk factor for any patient with bleomycin toxicity?
Basically, the risk factors for bleomycin toxicity are patients with upfront lung involvement, then patients with upfront hypoxia who would in turn require oxygen, and patients with renal RFT derangement, that is increased serum creatinine.
No, I think that since this is a mock examination, I think you have to be little bit specific. So suppose any patient with having a, so you should come up with a creatinine clearance that this renal dysfunction, it may be 1.2, 1.6, 1.8, 2, 3. So I think in exam you have to be a little bit clear. With this creatinine clearance, I will like to be, I will like not to use. So what is the creatinine clearance? How the renal function affects the bleomycin metabolism or dose modification?
Less than when the creat clearance is less than 40, there is a dose modification.
I think you have to be a little bit sure on that. It's not 40. So in the examination, you have to read very well regarding the bleo, because that is very close to the examiner. And even in day-to-day practice, we have to, that is the drug which is one of the, I feel, difficult drug to deliver if you do not monitor. So you told one is the renal function you want to see. What are the other factors for bleomycin toxicity?
Other thing is using growth factors, so that increases bleomycin toxicity.
Is it so? I think other one can also, Dr. Linu can also. So you don't give bleomycin, GCS with bleomycin at all?
Not at all, sir. But there is some data saying that it increases the oxygen derived free radicals.
So I think what you should do is that you should go to the original BP, the original regime, and just check whether they have given growth factors and how they have given growth factors. The original BP regime, when they developed, whether they have given growth factors or not. So I already gave the clue that how they have given the growth factors. So that means growth factors were used.
Yes, actually, the recommendation is not to delay chemotherapy.
There is a theoretical concern, and the theoretical concern is more practical in which disease, in which other disease,
yes,
when you along with the GCSF.
GCSF. We are more worried of that.
More worried.
Hodgkin's lymphoma.
Yes.
Yes.
Age, is it a risk factor for bleomycin?
Yes, higher age, older patients tend to have more.
Then again, you have to be specific. I will say 70 year is a higher age. So again, I told you, we be specific. Higher age means higher may be a 70 year for me, 30 year for someone. So you have to define the age. 40,
age above 50 years.
So you have to be specific. Don't say higher or lower. Other important? Smoking history.
Any history of smoking?
Yes. So you have to be read about the drugs related to that particular tumor.
You just one more question. Supposing you have a patient of a seminoma and a non-seminoma. In the seminoma versus non-seminoma, in which type would you like to avoid use of bleomycin?
In seminoma, I would prefer to avoid.
Why?
No, sir.
How does seminoma heal?
In non-seminoma, I would like to avoid.
Why?
Because at the end, if there's a residual disease more than 1 centimeter, I would like to go ahead with surgery. So when I go ahead with surgery, I will be exposing the patient to a ventilator, which again increases the pulmonary toxicity of bleomycin.
I would disagree. You go and read again.
Why do you?
It is seminoma. In seminoma, I would like to avoid the use of bleomycin. And testicular versus mediastinal GCT, where you would like to avoid bleomycin?
I'm not sure.
Where would you give RT if you want to give?
That is in the mediastinum.
Yeah, it's a pure logic. No, you are especially primary mediastinal germ cell tumors. most of them will have to undergo some amount of residual disease will be there, and most of them will have to undergo surgery. So wherever a major thoracic surgery is anticipated, that is another indication for replacing bleomycin with or replacing BEP with VIP.
Why do you want to give bleomycin in germ cell tumors? What is the data for it? You don't give bleomycin in stage 2 low risk or intermediate risk, but why do you give it in high risk?
Actually, initial trial for bleomycin was done by the Southwest Oncology Group and then proven by Dr. Ainon in Indiana, where they compared PVB with PEP, and they found that there was about 12% benefit of giving bleomycin over.
What does bleomycin do? What does it increase in the tumor?
What does it do in testicular tumors?
Yeah.
What did they find on the retroperitoneal lymph node biopsies when they had used bleomycin? It's a more specific.
I am not sure about this.
They showed more necrosis on the tumor specimens.
And there was more differentiation towards a teratoma in those patients where bleomycin was induced compared to where bleomycin was not used.
Okay, so coming back to this particular patient, you started with EP, you wanted to give for how many days? 3 days?
3 days.
Yeah, then what you will do?
Taken
care of the tumor lysis also. And just one more point with regard to this particular patient, what other imaging you would have asked for? What you would specifically be interested in looking at?
MRI
brains. Who has got a beta HCG more than,
MRI brains.
Yeah, fine. So there is no brain mets. Let's say tell that there is no brain metastasis. So
also leptomeninges.
So patient has received 3 days, and thereafter how will you manage? Subsequent management.
Then after that, I would like to do the markers again, sir. So if there is fall in marker levels, then I would like to.
Why you want to repeat the markers?
I will know that the disease is responding to chemotherapy.
So even if the tumor, so in a day-to-day practice, after giving first cycle of chemotherapy, what you expect, or at least in this patient? Suppose the tumor marker has risen to 15 to 17 lakh.
There could be a tumor flare, sir.
So then why you need to do the tumor marker?
Then I'll go ahead with the chemotherapy with VIPs.
So most of the patient, how you judge? Most of them they respond. What is the best way to assess the response of a chemotherapy? The clinical examination. The patient starts after 4 or 5 days. Patient starts improvement in all the parameters. You don't need to do the tumor marker. In fact, rather the other way, the tumor marker may be falsely rise even after first cycle of chemotherapy. You don't need to repeat the tumor markers. Just see the patient clinically. Dyspnea is settling down. Cough is settling down. Overall general improvement. You know that the regime is working.
Yes. So then I would like to move on to VIP based chemotherapy.
So after 2, you have given him VIP. Then how many cycles you like to give?
I would like to give 4 more cycles of VIPs.
Do you like to see the tumor marker?
After the second cycle, I would like to repeat the tumor marker.
So there are 2 scenarios. One scenario, tumor marker decreasing. Second scenario, tumor marker rising after 2 cycles.
If tumor marker is rising, that means there is a resistance to chemotherapy. So we need to change the line of chemotherapy and give second line chemotherapy. If the tumor marker is improving, then we have
data to suggest that after 2 cycles, the management as per the decline or fall in tumor marker, changing therapy helps in outcome.
I'm not sure.
So generally, till whatever the data, I think only there is one study which has shown that if you change the chemotherapy or add the gemcitabine and paclitaxel in the I think it was a French regime in which the after as per the decline of the tumor marker, they changed the therapy. So there is some improvement in the PFS, but because of the more toxicity in that regime, the overall survival was same. So even if we do the tumor marker, but we generally avoid the change. We know that patient is not going to do very well, even if the tumor marker has not fallen, but changing therapy till now has not shown the benefit in terms of survival.
Proceed.
Yes, so basically, then I would like about 4 weeks later, I would like to get the imaging repeated, sir, along with all the markers repeated again. And based on the imaging findings, I would like to move on to the next plan. So for imaging, I would like to do a CT scan.
All the markers have normalized. In imaging, there is a residue. In abdomen and in lung metastasis, also some residue is there. Markers normal.
Size of the residue in the abdomen, sir?
Around 3.5 centimeters.
Okay. So basically, in abdomen, if there is a disease more than 1 centimeter, it is an indication to go ahead and do a surgery and remove the residual disease. And in
why
lung,
it is important to do the? Do you need to do PET CT?
In non-seminomatous germ cell tumor, no, sir. PET CT is not recommended because the teratoma component that might be present will not have any uptake. Plus, it does not give any extra information beyond what is given by CT.
So why you need to remove the residual region? Why you need to?
What happens in what they found that in tumors which are more than 1 centimeter, 40% of the times they'll have teratomas which do not respond to chemotherapy. 40% of the times it's necrosis, and 20% of the time they can have residual tumors.
So what problem you will expect from a teratoma?
Growing teratoma syndrome can occur. So that will not respond to chemotherapy and it will have to be surgically resected.
Other problem? This is one issue. Other issue?
It can turn into a immature teratoma and again.
Other specific. Let it convert to immature teratoma. What is the other problem of keeping teratoma in long term?
Sarcoma.
They may transform because they have a layer of all the three lines, so they may transform into the
ना तो चार्जिंग ले रहा है ना बैटरी शो कर रहा है.
Hello.
I think there is some interruption.
Someone has.
I think you have to unmute all. I think others. There is a lot of disturbance.
Yeah. So basically, that is the region which was mentioned because they may have transformed into the other malignancy in future. So you have to remove the whatever residual there. Okay. So suppose patient has no disease, surgery has been done, no residual disease in that, and then after a follow-up after 6 months, again tumor marker started rising. Then how you will proceed in that case?
So if tumor markers start rising, again I will repeat the initial staging investigations and see if I can find any disease.
So there are reappearance of multiple pulmonary lesion in the lung.
Okay, so then I would like to give second line chemotherapy, salvage chemotherapy.
So how you will proceed then? But I could not hear you.
I would repeat the markers, imaging. Then I would like to proceed with salvage chemotherapy, and yes.
Again, you have to be specific. Which salvage? There are 4 or 5 types of salvage chemotherapy. Which salvage chemotherapy? What are the options? So how you like to?
IPO.
Sorry.
IPO, ifosfamide platinum and oxaliplatin, the paclitaxel and oxaliplatin.
What is the regime called?
This is the very commonly used regime. You have to name it.
IPO, sir. IPO.
No, I think it's TIP. TIP. And what are the doses of the standard original TIP?
So taxane is 250 milligram per meter square, sir. Ifosfamide is
and how
250 milligram
given over 24 hours.
Yes, that is most important in that regime.
And platinum is 100 milligram per meter square, and ifosfamide is comes to.
So 20. So you have to. It's okay. Not. Is there any other option? Is there any other option apart from the TIP, or TIP is the only option in this patient?
VEIP, sir.
Apart from chemotherapy.
VEIP, sir.
Apart from
So the Indiana protocol can be used, sir, where in first relapse they have used autologous bone marrow tandem autologous bone marrow
Yes,
transplantation
so that you
with
have to be sure
carboplatin
that
and etoposide.
yes, so still the role of the autologous BMT in first relapse testicular cancer is evolving. Is there any randomized trial going on?
The Tiger trial is going on right
Yes.
now, sir.
So there are. So you have to be specific that there is two options are there. So TIP is one of the option, and the second option is autologous BMT. So you have to say that there are two options are there: the TIP and the autologous BMT with the high dose chemotherapy. So both are. Don't know whether this one is better or the Tiger trial will give us the real answer whether TIP is beneficial or autologous BMT. So you have to be clear. In which patient population you don't want to avoid a TIP or don't want to use TIP, or where the results of TIP has not been very great, which relapse setting? That's a gold medal question.
Late relapses.
Other apart from that, nothing works in late relapse. Late relapse has to be treated preferably if it is surgically solvable, better to remove and then give whatever you want. So nothing works chemotherapy major in that. But I meant to.
What is the refractory disease and absolute refractory disease?
Yes, that is the real.
Absolute refractory disease is disease that progresses on chemotherapy or within 1 month after it.
Yes.
So one is which progresses while on therapy, and the other refractory diseases?
Refractory disease.
You can't combine both. So absolute refractory is one which progresses while on therapy, whereas a refractory disease is one
is
which
within a month, sir.
Within a month, yeah, within 4 weeks of the last dose of cisplatin. So what about the conventional chemotherapy in refractory and absolute refractory disease?
You can use VIP, sir, vinblastine, ifosfamide, and platinum.
No. Conventional versus high dose. That's what we are asking. And also, any importance to the site?
Yes.
You must be knowing about Bayer score, Einhorn score.
Yes, sir. So mediastinal primaries don't do very well, sir, with retroperitoneal.
So basically, so in the TIP study, they have not taken those patients.
Then.
Okay, so what is the chance of a CR with conventional dose chemotherapy, and what is the chance of a CR with autologous
BMT?
The chance of a CR with when used in first relapse with autologous, as per the Indiana study, is 70%. And with conventional chemotherapy, it is between 50 to 60%.
Yeah, so 70%. I'm not very sure. Maybe maybe.
No, I think
it was somewhere around 50%.
In the range of. If you indirectly compare the results of both, seems to be equal. But what Dr. Linu was saying that patient of a mediastinal germ cell tumor, patient of a refractory disease in the TIP study, they have not taken those patients, so that their results seems to be slightly better, but they have not taken the real bad one. So if you indirectly see, result looks like to be the same, but in the Einhorn group, there was a mixed bag of the patients. So results are more in the range of 50-60% long-term result. So I think we have what are the long-term side effects of patient has completed his treatment, everything is fine. What additional advice you would like to give to the patient, and how you will follow in future?
So the follow-up for this patient, I would like to do clinical examination every 3 months for the first 1 year, every 6 months for the second and third year. And so during clinical examination, I would also like to do markers. And then after the third year, I would like to do a clinic. I would like to examine him once a year. I would like to do imaging 6 monthly in the first 2 years, and
no, but I meant to see what are the long-term complication of patient who has treated with the testicular cancer, or the long-term complication you have seen, which you can expect.
Okay, one thing is infertility. Next thing is the bleomycin-induced lung toxicity. Next thing is the cisplatin-induced ototoxicity, as well as neurotoxicities. Cisplatin-induced interstitial lung disease, restrictive lung disease.
These are mostly, we can't do much in this. Tell me the one complication where we can do something, we can prevent, or we can do something to prevent those, or we can treat few of those complications. Suppose the patient develops a cisplatin autotoxicity, you don't have anything to offer. If the patient has developed a neuropathy, platinum is not nothing, but there is some complication which is associated with the platinum-based chemotherapy where we can do some preventive or some treatment we can be considered. So it's a metabolic syndrome. So these patients have increased chances of what we use as syndrome X, or they have a lipid abnormality. They have increased chances of cardiovascular mortality. So these with the education, with the counseling, definitely you can reduce. So the blood pressure, hypertension. So the overall cardiac mortality of these group of the patient is 2 times more common than the normal age cohort. That there you can do something to prevent those long-term complication. Another important toxicity you have not mentioned of the etoposide, that every examiner wants to listen. Long-term toxicity of etoposide.
Secondary malignancies, secondary AMLs.
So how it is? So what type of secondary malignancy do you see with the chemotherapeutic agents?
Acute myeloid leukemia and myelodysplastic syndromes are common, sir.
So how it is different from other? So how the etoposide induced and the other alkylator induced leukemia are different? Is there any different pathophysiology or something?
Actually, the prognosis in etoposide induced secondary malignancies are not that bad, sir.
Before that, any difference? Timing and something?
What is the latent period?
Yes.
It appears within 2 to 3 years.
Yes. So what I mean, you have to be a little bit ready with the. You have to read about little bit about the long-term complication associated with platinum-based chemotherapy, etoposide. So if your Viva is going well, definitely examiner want to know about the long-term complication of these treatments. You have to be little bit read about this. Then the Viva may go into the leukemia, the drug-induced leukemia. Then you have to differentiate between the early and the late, the chromosomal abnormality. So you have to be prepared with the doses of the etoposide. How what is the leukemogenic dose, or what are the chances of developing secondary leukemia with? Is there any dose relation?
2 grams. More than 2 grams is increases the risk of developing secondary leukemia.
How much? So you have to be specific. You have to decreases, but how? So I think that is the purpose of asking this question. I think Dr. Linu or Dr. Venkat can ask anything.
Yeah. Do we have time?
We have another half an hour, sir. We can take questions from students.
Yeah. So just I just wanted to ask, when you told about the complications, infertility, do you think that the sperm quality will increase post chemotherapy, or it is going to further go down?
Actually, after 2 to 3 years of chemotherapy, there is a return back of normal spermatogenesis.
No, I'm asking, like, the chemotherapy is going to improve the sperm quality or decrease the sperm quality, and what is the explanation?
Yes, I'm not sure.
Okay, fine. So now you have given salvage treatment for this particular patient. So at the end of the salvage treatment, you have residual disease. So what is the size based on which you will go for consolidation surgery?
Any non-seminomatous germ cell tumor, anything above 1 centimeter, I would like to go for surgery.
So ideally speaking, irrespective of the size, wherever there is a residual disease, post salvage, you should go and remove the disease. And what is the likelihood of teratoma necrosis and viable disease in the post salvage setting?
Post salvage setting, the viable disease is about 7%, sir. Complete necrosis is about 47%, and teratoma is about 50%.
Just compare and tell what is the in the post first line and post salvage.
So first line, it is 40% teratoma, 40% necrosis, and 20% residual disease, sir. So post salvage, the residual disease comes to 7%, sir. And necrosis comes
so
to
that means the
55%.
viable disease, the chance of detecting viable disease post salvage is less than in the first line setting.
Yes, sir.
Is it? Okay, so supposing post consolidation, so that you should go and check what is the percentage. Actually, how we remember is that 50, 40, and 10. 50 is necrosis, 40 is teratoma, 10 is viable in the upfront. Okay.
Okay.
So the necrosis will become 10%. Teratoma will remain the same. Viable disease will go up.
Okay.
A 50% chance of detecting
Main participants in question in
the post-salvage setting. Not 7%. It actually goes up.
Okay.
Okay. What is desperation surgery?
Desperation surgery is post 2 lines of post salvage chemotherapy. There is only a single site of residual disease with marker elevation. Then you just go and operate that particular site of disease, and in around 30% of the cases, that will cause the marker elevation to drop.
So with which marker elevation patient is likely to do well? Beta HCG or alpha fetoprotein?
Alpha fetoprotein.
Okay. Fine. So would you like to give any chemotherapy for a patient with residual viable disease post consolidation surgery after salvage chemo?
After salvage chemo?
Yeah. You have done salvage chemo. There was a residual disease. You did consolidation surgery, resected the residual disease. Pathology tells that there is viable disease. Okay, so that also you can go and check. So with that, I'll conclude. Over to Dr. Venkat.
So what is the difference between adult testicular germ cell tumor and pediatric testicular germ cell tumors?
Yes, I'm not sure.
At least make an attempt in terms of staging, pathology, treatment. Okay, let's start. Is carboplatin used in pediatric germ cell tumors?
Yes, sir. Carboplatin is used in pediatric germ cell.
What is that regimen called?
PVB, sir.
No. JEB.
JEB, sorry.
What is J?
J is carboplatin.
Why? It actually stands for JM8. It was an old name for carboplatin.
Oh.
So why is carboplatin not used in adult germ cell tumors?
There is a study that has proven that using carboplatin is inferior, sir, to using.
Yeah, so there was a randomized trial, but why does it work in children? So actually, they're planning a randomized trial in adults and children as well. It's called the MAGIC trial, comparing carboplatin and cisplatin. One theory is that the dose of carboplatin in JEB is AUC 7.9. It's quite a high dose, whereas the dose used in adult trials was around AUC 5. So it is believed that probably if you go up on the dose of carboplatin, it might work. Only the MAGIC trial results will tell. Okay, then what is a common genetic abnormality seen in adult germ cell tumor?
Isochromosome 12p.
Yes, it is not seen in pediatric germ cell tumors. What is seen?
Not sure.
Loss of chromosome 1p is commonly seen. Del 1p is seen. Okay, what is the cutoff for taking somebody as pediatric germ cell tumor?
14 years.
No, 11. So again, there's this MAGIC consortium which looked at risk factors for pediatric germ cell tumors. Children less than 11 tend to behave like the pediatric tumors. Children more than 11 years are to be treated like adults because they tend to behave like adults. In terms of staging, what staging do you use in children?
I'm not sure.
It's called the Children's Oncology Group staging. So read up how is the COG staging different from your classical TNM and IJCCG staging. How does it differ? So that is also very important to understand what is the difference among all those things. Then what else do I want to ask? That's it. I don't think so. I have anything else to ask you.
In adults, where we use carboplatin in germ cell tumor, this scenario? That you have to answer this question. You can't say
The seminoma, sir. Stage 1 seminoma, AUC 7 carboplatin.
So how you calculate the dose?
There you have to do a DTPS scan, sir. and check the creat clearance based on DTPA. And then
DTPA is not available. Then what is the other alternative? Suppose DTPA is not, you will not give a patient.
No, then we have to use the Coxford-Gault formula.
No, that is the wrong answer. So how you say carboplatin in a stage? So let's discuss about something about stage 1 tumor, because sometimes. So you say that in stage 1 seminoma, what are the treatment options? So suppose the patient has come up with the CT abdomen pelvis doesn't show anything, everything is normal, and the histopathology says the stage 1. So how you will like to proceed in this case? What other information you want to know, and what are the options you will discuss?
So basically, there are three options. Basically, I would like to know the tumor size.
Say 8 centimeter.
Okay. So basically, they say tumor size more than 4 centimeter in presence of LVI, they have an increased risk of failure in the abdomen in seminoma. Sir. There are,
Is it
MRC
that
studies.
No,
sir. Just two MRC studies have shown it, but it's not yet a part of the guidelines.
Yes.
So basically, there are three options. Sir. The three
Yes.
options are active surveillance, radiation, or giving carboplatin. Radiation only to the paraaortic bed, and carboplatin AUC7. Again, there's an argument between giving one and
to
two
prefer
cycles.
among all three. Patient is well educated. Which one you want to choose in this?
I would choose carboplatin AUC7, sir. Single cycle.
Why?
One thing is
surveillance. I will go for a surveillance. I told you, patient is educated. He is ready to follow up. So, is there anything? Why you want to give him carboplatin? Ultimately, it's a chemotherapy.
Yes, sir. But one thing is the apprehension and the kind of follow-up that active surveillance requires you to actually do imaging at a repeated interval, and that would increase his.
I told you, patient is educated. Why do you think that carboplatin does not have any toxicity?
Carboplatin does have toxicity.
So preferred option is what the current guidelines or current literature says, that you have to. The preferred option is active surveillance. Then the option of these two you can discuss. Your radiation oncologist will say that I will like to give him radiotherapy, and you want to give him carboplatin. So how you will convince the patient for chemotherapy?
Basically,
you have to send the patient for radiotherapy also. Radiation oncologist opinion also. So what are the in favor of carboplatin you want to discuss with the patient?
Basically, it reduces the risk of contralateral testicular malignancies. And
apart
the
from
long-term side,
this is the
there are no
byproduct. Other important thing which are not in where the radiation can cause some issues.
It can cause secondary malignancies. It can cause,
any difference between the survival between these two? Was the trial which was then the famous trial for this stage 1?
This is T19. MRC T19.
So that's a big MRC group trial. So is there a difference in the? There was no difference in the survival in these two.
More or less statistically significant. So the 99 and 96.
Basically, you have to discuss about the problem associated with long-term radiotherapy, and the carboplatin may better in that point of view. And definitely, the second thing is that it decreases the chance of second testicular cancer in future.
What percentage of the patients on active surveillance will develop a relapse?
15 to 20%.
Yeah, so only 20% of the patients are going to relapse. Correct. So you are so if you give radiation or chemotherapy, you are unnecessarily treating what percentage of the patients?
And what is the outcome of those relapse patients? The 20% after you treat them again?
Very good, sir. Very good. It's almost 95% above is the chance of cure.
It's close to 99 or 100 because all patients always with the chemotherapy. So therefore, you need a more strict follow-up or more stringent follow-up to see the relapse, and then you can treat those early. So the cause-specific survival remains same in both, whether you give them surveillance, put in them surveillance, or give them chemotherapy.
What is the disadvantage? One of the major disadvantages of follow-up with respect to seminoma, this 20.
It can be over a period of 5 years,
No.
So
most commonly in 2 years, but
usually they tell
it
up
can
to 10 years.
Up to 10 years.
Relapses over
Late
a period of
relapses
10
are common. Yes, the late relapses are more common in seminoma than the NSGCT.
So the thing is that you have to subject these patients to long-term follow-up as against NSGCT, where you can follow up maybe, yeah. So I think we have grilled him enough. We will finish.
Yes, I agree with you.
I think we will ask open house any questions, students or anyone. 1 or 2 questions we can take. We're going to start at 11:30. So can we have any students can raise the hand?
I had a question, sir.
Go ahead.
Sir, actually, when we look at marker falling post surgery, we look at marker falling in order to grade the patient into S0, S1, S2. No, sir? Should we wait for 5 half-lives or 3 half-lives? Sir? Hello. Yes, hello, sir.
You should address to your faculty, yeah?
Sir.
Sir, you will take the call.
Hello.
Sir, the question was, sir, after doing an orchidectomy and you're waiting for
So
markers.
your question is primarily with respect to that the staging of germ cell tumors, the post-operative marker is the one which is significant. That significance is only for probably a stage 1 testicular tumor. So how many half-lives will you wait? The half-life of beta HCG is 1 day, and the half-life of alpha-fetoprotein is for 1 week. Correct? No. When the patient is already having retroperitoneal disease or lung metastasis, or for example, in this particular case, liver metastasis, post-surgery, supposing the patient has undergone high inguinal orchidectomy, do you think that you will wait for 5 weeks to start the treatment? Practically, it is not possible. Only in stage 1 diseases where you want to make it sure whether it is 1S or 1A or 1B, this question arises. Otherwise, it is immaterial. Five half-lives means how it is possible. So post high inguinal orchidectomy, I will start my treatment within 2 weeks.
Maximum 2 weeks.
Or once the surgeon gives me the go-ahead. So practically it is not possible when there is so much of retroperitoneal disease, lung mets, liver mets. Where is a question of waiting for 5 half-lives?
If there is nothing of that.
It is relevant only in stage 1 disease.
Yes, sir. Then we wait for 5, sir.
Yes, you can wait up to the tumor marker. So then you have to see the trend, how the tumor marker are falling. If they are falling as per their half-life, you can wait. So generally 3 to 4 weeks safely you can wait. You can wait because there is no disease in the retroperitoneum, no disease in the lung. So then you can wait. But if there is already a 4 or 5 centimeter retroperitoneal lymphadenopathy waiting for 5 weeks, so I generally start within say 7 days or 10 days the marker level at that point of time.
One more thing, sir. Am I wrong in saying, sir, in case a scrotal orchidectomy has been done, I will not do a scrotectomy. If I'm giving chemotherapy to a patient, I need not do scrotectomy. Am I wrong in saying that?
Yeah, you need not. As I told, we discussed already simple orchidectomy versus radical orchidectomy. In the initial days, maybe in the 1920s and 30s, they thought that there is a high chance of local recurrence. But the latest studies are showing that the recurrence is only to the tune of around 3 to 9%, and maybe around 3%. Some studies showing some 7%. But ultimately, it doesn't alter the prognosis or the survival. So you can wait. If the local recurrence is there, you can treat. Okay. And many a times when you give the chemotherapy, even that risk of scrotal violation is also there.
Yeah, you don't need to do hemiscrotectomy if you're giving chemotherapy to sterilize it.
Okay. Yes. So if you are keeping the patient on surveillance, then the revision of scar can be very a question. For a stage 1 disease, when you want to keep the patient under surveillance, then there is a theoretical possibility that do we want to do it. But if you are giving chemotherapy to this patient, theoretically the disease which may be present in that scrotal scar will be sterilized. If the chemo is working on the node, and then why it will not work on the tumor which may be there in the scrotal scar? So generally, and some surgeon too, when they are going for RPLND, they do the scrotal scar revision. But whether it is really helpful or not, we don't know. So even we do not recommend to go for scrotal revision after.
So the answer should be it increases the local recurrence, but it doesn't alter the
survival.
So you can wait, and if the patient develops a local recurrence at that point of time, you can treat.
Sir,
I think others would agree with me.
Sir, after giving first-line chemotherapy, there's residual disease. You operate, and once you operate, also you find residual tumor. Now there is some conflicting opinion if complete tumor has been removed, whether to give 2 more cycles of chemotherapy or observation, because the trial data is not showing an improved survival with giving 2 more. So what would be the right answer?
I think I would dissect in 2 ways. One is patient who's having high burden disease. In high burden disease, post chemotherapy, RPLND, if there is viable disease, definitely you have to give 2 cycles of EP. Some give 2 cycles of EP, some give 2 cycles of BEP. So, but again, bleomycin, you have to cap the dose. That you have to always remember.
Even we avoid giving etoposide because the patient has received 4 cycle of BEP, so we change to them to tip or something. So in conventional teaching, if there is a residual disease, whether it is totally removed, still it's better to say that I will like to go ahead with 2 more cycle of chemotherapy.
I think 2 cycles of EP is not a wrong answer actually.
Yes, 2 cycle of EP, both all are the options.
The other scenario which I wanted to discuss was in the case of a stage 1 non-seminomatous germ cell tumor, maybe 1B, where you decide to go for a retroperitoneal lymph node dissection, or in a stage 2 low volume disease where you go for retroperitoneal lymph node dissection. You can get away with chemotherapy. So if you will classify it as PN1 and PN2, and PN1 is one area where probably you need not give further chemotherapy, whereas in PN2 they usually give further chemotherapy. So those are the 2 scenarios when you discuss upon retroperitoneal lymph node dissection. So one is post chemotherapy, one is primary RPLND for an early stage disease.
So how you will decide the treatment for a stage 1 NSGCT? What are the 2 most important risk factors you will consider in decision making for stage 1 NSGCT? Tumor marker are normalized, no disease in the imaging,
embryonal component more than 4%, and LVIs.
Yes, so the LVI will come first. So LVI is the most important, followed by the embryonal. How will you treat these patients?
Embryonal.
How you will treat?
I will give them 2 cycles of BEP, sir. If
how many
both these risk factors are present, I mean, if embryonal component and LVI both are present, 2 cycles of BEP.
So I think now the word is gradually moving to in the stage 1 high risk. Gradually the stage even 1 cycle of BP is sufficient. So the word is gradually moving from 2 to 1. So now we generally consider for 1 cycle, even stage 1 high risk, we consider 1 cycle of B. But even if you say 2 is okay, but the shift is gradually, and there is a randomized study which has shown that 1 cycle of BP is good enough for these patients to prevent the long-term toxicity of these patients.
I think one question is from student Ravi. I'm unmuting Ravi. Can ask the question.
Hello.
Yes.
Sir, I always wanted to ask this question that if a young fit patient who's asymptomatic for his pulmonary metastasis, and on the scan there is disseminated pulmonary metastasis, if such question is asked in exam, what should we say about bleomycin? Should we use or should we not use? Second question is, in mediastinal germ cell tumor, they say that use bleomycin with caution. But how should we again answer this question in exam for bleomycin? And the third is about DLCO. We are not doing DLCO in our institute. Any comments on the DLCO? What should we say? Those 3 questions.
I think I will take second question first. I think Dr. Nilo has clearly told that in patients of a mediastinal NSGCT, where the possibility of post chemotherapy surgical resection is high, we know that the mediastinal NSGCT doesn't respond that well, and majority of the patient will have a residual disease. So in a real world practice, we consider them for VIP because majority of the patient will require surgery, and the bleo is going to be a problem for surgery. This will be a major surgery. So for a mediastinal NSGCT, VIP is most of the time is the preferred regime. Regarding your first question for the asymptomatic multiple pulmonary metastasis. So in a practical scenario, when we know that there are multiple lung metastasis, even a slight deterioration in lung function can be detrimental for these patients. So from a practical point of view, in patients who are disseminated lung metastasis, I generally do not recommend the bleomycin, and we know that the VIP and this BP from the survival point of view more or less same, and the toxicity was more. But with the GCSF, all that we can compensate for that toxicity. Regarding the DLCO, we in Tata do DLCO. I usually repeat after 2 cycles. If there is a fall in 25%, even patient remains symptomatic, I usually consider changing to that. If you go to the even literature of the drug manufacturer, they say that DLCO can be done. But if you say that is it the sacrosanct that if the DLCO is less than 40%, we can't use, no, that is not the data. But in a practical scenario, if DLCO is less than 60, people tend to avoid the bleomycin. Or there is a fall of the magnitude in around 20-25% fall, you can consider. But the literature says the most important point to prevent the bleomycin toxicity is the clinical examination and suspicion of toxicity. So any patient who develops unexplained cough while on bleomycin, which is not explained by viral or any other thing, you have to be sure and get a HRCT to rule out. I think other can pitch in. In Tata, we do DLCO in each patient we are considering bleomycin. I think Dr. Linu can comment on that if there is some other.
Yeah, so we don't do it at our institute, but we routinely send to we have an institute nearby, Rajiv Gandhi Institute, so and we get the DLCO done. But I think the most important thing is that for every time the patient visits, you should keep on asking the history of dry cough, on exertion. I think that is most important, so clinically to detect. And so I think what the student who asked the question, they can always tell in the exam that, okay, this is what is recommended, but in our institute, this is what is being followed for the exam purpose. But I think otherwise, almost all the institutes, I think they are doing DLCO, there is no doubt.
Thank you, sir. Thank you, sir.
Dr. Vinayak, I am leaving. I have another meeting to attend in the Residents Association, so I am leaving.
No, thank you, sir. Thank you very much. I think we are done. 11:30 will start next session. I think I want to thank all the examiners for a very comprehensive and very lucid answers and questions. I think Dr. Next panel will be joining shortly. Thank you, sir.
Thank you, sir.
So, any questions? I think we are close. I think 11:30 is the time we are given. Our examiner, Dr. Raghunath Rao sir, will join us at 11:30. Dr. Prashant, I think you all know, is from JIPMER. He is a additional professor and as well as head of the department in JIPMER. Dr. Prashant, can you speak up? I think I'll unmute you.
Hi everybody. Hi, Dr. Vinayak. Thanks for the opportunity. Thanks, Shashi. So, looking forward to interesting session. There is a lot of information to be shared with everybody, and it's useful for all the postgraduates. I see a good number joined on Sundays, almost 68 participants, which is very good. I think very good initiative by your group. Very useful, especially because regular programs like COPE did not happen this year because of the COVID pandemic. So I think this is a good way for all the postgraduates to learn from all the examiners and from each other. So, excellent. So looking forward. Hope you can hear me well, Shashi.
Yeah, Prashant, audible. Thank you so much for joining.
No.
So I will call Dr. Loknath sir, who is the head of the department medical oncology in Kidwai. Sir, can you? I have unmuted you, sir. Can you talk?
So am I audible to you?
Yes, sir.
Audible.
Yeah. Good morning, everyone.
Morning.
I really appreciate the efforts of Dr. Vinayak in arranging such a good scientific session for the students, and trying to utilize the experience of our faculty. I think I'm eagerly waiting. Let us see how this. I was in actually I was in a germ cell tumor meeting. There's a little problem for me to communicate to you all. So now I hope everything is set right now. I think we'll see. I'm waiting for the case presentation. Thank you, Vinayaka.
Thank you, sir. So the third examiner will be by me. So I'm from Professor and Head of Department of Medical Oncology at Ramaya Medical College. Our expert faculty from Ramaya will be Dr. Santosh. He has seen the case and he will help us with the patient's details. I just open this.
Not audible, Vinayak.
I think Santosh is not able to unmute it actually. Can you hear me?
Yeah, I'm here.
Now it's clear.
I'm here, Dr. Vinayak.
Yeah. So he'll be the expert for this case. Any of the faculty can write. And I want to thank again Dr. Rohit for Roshan for helping for the previous case. So we can wait. Anyone has any questions? We are waiting for sir. Once the sir comes, we will start the sessions. I will call Dr. Madhuri, who is the presenter for this talk. Madhuri, can you hear us?
Yes, sir.
Yeah. So, any other?
Madhuri, can you speak up a bit? I could not hear you very well. Can you just speak up a bit, just to make sure that we can hear you well?
Yes, sir. Can you hear? Yes.
Yeah, that's fine. That's fine. Thank you.
Sir has come, so I think I'll introduce sir and then we'll start the session. That should be. Good morning, sir. Can you hear me, sir?
Yeah, I can hear you.
So I think.
Good morning, Prashant. How are you? Good morning,
sir.
Vinayak. How are you?
I'm fine, sir.
Okay.
Good to see you, sir.
Wonderful.
Very, very good to see you, sir.
I don't think anyone needs to introduce sir, but still for honors, sir is a professor and a director of Homi Baba Cancer Hospital in Vizag. I think the few people who actually have impact on most of the residents is one is the COP by ADR and second sir is a young oncology meeting. I think most of them are well versed. Sir, we will start the case, sir.
Please. I'm ready.
The case presentation will be Dr. Madhuri. Madhuri, can start. You can introduce yourself and start.
Yes, I'm Dr. Madhuri.
Yeah, we need to see you, Madhuri. We need to read your face, your expressions.
Yes.
Madhuri, you have to be a little louder.
Madhuri, be close to the mic. Huh?
Yes, sir.
This is okay now. Yeah, please.
Good.
Sir, I'll be presenting the case in the PPT, sir. I'll just share my screen. She's a 56-year-old female, housewife by occupation and a resident of Bangalore. She presented with complaints of lump in the right breast since 3 months and pain in the right breast since 1 month. The patient was apparently all right 3 months back when she noticed lump in the right breast. At that time, it was small in size. She has described it like a size of a lemon, which has gradually increased to the present size. It was associated with pain, which was occasional and dull aching with no specific aggravating and relieving factors. There is no history of nipple discharge, redness, ulceration, or bleeding. There is no history of fullness or mass in the armpit or in the opposite breast. There is no history of limb swelling. There is no history of decreased appetite or weight loss. And there is no history of breathlessness, cough, bone pain, jaundice, abdomen symptoms, or headache. Past history, she is a known diabetic, hypertensive, and hypothyroid. There is no history of prior breast biopsies or breast surgery or no other prior surgeries in the past. No history of prior radiation to the chest. Family history, there is no history of similar complaints in the family, and there is no other significant family history. Menstrual history.
Madhuri, can you just go back to the
Yes.
Fast history you're telling. Just go back.
Lakshmaya sir,
Sir, Loknath sir.
Loknada, how are
Good
you?
morning. Good morning, sir.
Good morning. Nice to hear your voice again.
I am also, sir. I am too.
Okay. You said size of a lemon. A lemon for a breast tumor is very big.
Yes, sir.
Okay, it's not a small tumor.
Yes.
Small tumors are those which are pea-sized.
Yes.
If you don't like a pea, you can say it is the size of a dal. Okay, arhar dal. So it just, if you palpate it, it just touches your fingers. Okay, a lemon is quite big, especially a Bengaluru lemon will be quite big.
And Madhuri, other thing is that he told no history of breathlessness or cough. Like,
Yes.
what do you mean? Why did you like ask that history of breathlessness and cough?
Just to rule out any metastatic disease, sir.
So how frequently do you say that patient will have breathlessness and cough with metastatic, unless until the patient has a massive effusion, isn't it?
Yes, sir.
So very often it is not from parenchymal disease. In breast cancer, typically the presentation is as a pleural effusion. That is what Professor Loknatha wants to tell you. Okay?
Okay.
And
that
the
is
other thing
important.
is that
So
the other thing you told jaundice, no? I see many of the students, they commit always that there is no
there is
stage,
never
jaundice, no
a
stage.
breast cancer patient with jaundice unless the entire liver is replaced.
Why do you say, why do you like, what is the intent of telling that there is no history of jaundice, Madhuri?
For liver mets only I had asked.
No, in your clinical experience, how many patients you have seen with jaundice? Even though you have seen a multiple metastasis, as sir said, no, like Raghunath Rao sir said. That's
Very
it, I
rare,
think.
very rare to find jaundice. Okay, so don't mention jaundice in the presentation unless you have some reason to believe that it may be related to your history. Okay, otherwise it is not very good to have a history of jaundice for a breast cancer patient. Okay, bone pain is all right, headache is all right,
all right.
breathlessness once again is all right, but anyway, it's not very relevant. Cough is a very uncommon symptom in breast cancer unless the whole parenchyma is gone. Okay,
yes,
right.
Yes.
Okay.
Next
If
slide.
I may just intervene, I think this is a common scenario because some examiners might want to know whether you have covered all the negative history. So the students tend to tell the negative history of all the metastatic sites, right? Like sir pointed out, jaundice and all those things are distinctly uncommon in a patient with breast cancer. So my suggestion to all of you would be just to present it as no symptoms suggestive of metastatic disease. And if the examiners ask what all you asked, then you can go into some specifics, like most important things like bone pain, all those things can be mentioned. If they ask further things, then you can go into that. Instead of committing all these things and unnecessarily your viva gets diverted into all these angles instead of going straight to the point. So this is my suggestion.
So you can just say, like what Dr. Prashant said, there is no history of metastatic disease indicative of symptoms from metastatic disease. Indicative symptoms, metastatic disease. That's what we want. Okay, go ahead.
Okay,
please.
Next slide.
Past history, she's a
Next slide.
Yes.
In menarche of 16 years, menstrual cycles are regular. She has 2 children.
You have to be slightly louder, Dr. Madhuri.
Loud.
She had 2 children. Age at first pregnancy is 21 years. Breastfeeding she has done for a total of 3 years for both the kids. There is no history of ossipils, and she became menopause at the age of 50 years.
Madhuri, in the menstrual history,
Yes.
what are the risk factors? How the patient is relevant to this history? Each of them you elaborated. How is it relevant to the patient increased chance of having this cancer?
Yes. Early menarche and late menopause are associated risk factors for developing breast cancers. The relative risk is less than 2. And age at first pregnancy, if the age at first pregnancy is more than 35 years, then the relative risk is 2 to 4. With breastfeeding, if the total duration of breastfeeding is more than 1 year, then again the relative risk is less than 2.
The voice is not clear, Madhuri. Just speak close to the mic.
Yes, sir.
Go ahead. Go ahead. Next, you go for this.
Madhuri, now I have a question. Since Vinayak Mas asked like a menstrual cycle,
yes.
Now a female was married and not conceived more than 30 years, and this other group, a lady was conceived after 30 years. Who has got the highest risk for a pregnancy? Is it a childbirth or a nulliparous after 30 years?
The age at first childbirth has more risks, sir, more than 35.
Now, among the two, who is that more risk? Is it who has conceived or not conceived?
The nulliparous woman has more risks, sir, than the woman who has conceived.
Why? What is the reason here? See, I'm telling you after more than 30 years. I'm not less than 30 years. Okay, we'll come to that later. I'll talk. We will have a discussion on that. And the other thing is that history of OC pill usage. Is it relevant?
Yes, sir. The use.
In what way it is relevant?
Again, the history of combined estrogen and progesterone pills is associated with increased risk, sir. And the.
Is it a combined or something else? What was the earlier OC pill and what is the present OC pill now? What is the dose combination and other things?
I'm not sure.
This is very important, no? Because, yeah, this is a very important thing because many women take OC pills in the current era also. And are you suggesting that any OC pill intake increases the risk of breast cancer?
Yes, sir. Combined OC pill has an increased risk, sir.
What component of the OC pills will cause increased risk of breast cancer?
The estrogen component, sir.
So how the combined pill have more risk?
So, and what is the strength also now available? OC pill strength. Both estrogen and progesterone. That is true, isn't it? You want to know?
Yes.
I think you need to read better about the OCP pills. They have protective action as well as detrimental action. I think when you say this comment, you should know the questions will come on that side. I think you've not been well versed, so we'll go for next slide. Is it okay, sir?
Yes. No.
Just remember that the modern day OC pill carries very little risk, okay, of breast cancer. So that is not likely to be worrisome. The pill which everybody is talking about as having an increased incidence for cancer is the pill which women are prescribed after they attain menopause for the sake of menopausal symptoms. That is not the pill we are talking here. That is what Dr. Loknath and Dr. Venkat want to tell you very clearly, that this is the pill which was taken as an OC pill. Okay, so they are completely different pills. So don't confuse one with the other. Okay.
Okay.
Go ahead.
Personally, married, mixed diet, sleep.
What is a mixed diet? They are vegetarians, non-vegetarians. That's all, no?
All students are committing suicide.
Okay, you can say she's a vegetarian, she's a non-vegetarian. That is fine. If they want to split, they will ask you, does she take milk? Does she take egg? Does she take this, that? No, that's all right. Okay.
Sleep and appetite are normal and nil addictions.
Okay, good.
No addictions. What do you mean by no addictions?
Because the alcohol intake is associated with the.
So she doesn't smoke and she doesn't drink. That is what you want to say.
Yes,
say that.
Yes.
That is best.
Okay.
She may be addicted to a cell phone. So don't worry about it. Just say that I have asked her the history of an addiction to alcohol
tobacco
or
consumption.
tobacco.
Okay.
Okay. Carry.
Addiction to either of them. Finished.
Okay. Summarizing the...
No, before going that, like with history, 56, no? 51 or
56.
56. 56 here with the presenting the breast lump. Since how long? Madhuri, can you hear me?
Sir, no, sir.
Hello.
Yes, sir.
Since how long she has got this breast lump?
3 months, sir.
So what is your clinical impression after once your symptoms?
History, Madhuri.
Yes, sir. She's a 56-year-old postmenopausal female
No,
present.
that is true. But what is your inference or what do you want to conclude on the history? Is it a CA breast, something else? Malignant?
It's a breast lump, sir.
Why do you say it is a malignant breast lump?
Because
what are the
what are the features, sir? She has no history of any fever, no significant pain. There is no history of any discharge, and it's like increased in size in the 3 months duration.
What is the first risk factor in this? What is the first risk factor? Age of the patient,
yes,
isn't it?
Yes, sir.
Age of the patient is the number one. Number, she has got a slowly growing lump in the breast, which is not associated with any discharge, isn't it? So
Yes.
3 months. So probably these two factors I would like to consider.
So any breast lump in a postmenopausal woman, okay, for that matter, any lump anywhere in a postmenopausal woman, uterus, ovary, or breast, it doesn't make any difference. Unless otherwise proven, it is malignant. Right? In a premenopausal woman, there can be 1,001 causes for a breast lump. Okay, that means only 1 in 8 to 1 in 20, depending upon the race you are studying, will turn out to be a breast cancer in a premenopausal woman. In a postmenopausal woman, a recent onset breast lump, unless otherwise proven, okay, by histology, is malignant. Then nothing else. Period. So this is a breast cancer. There is no doubt about it. Okay, take it like that. You must be categorical. Okay, breast is easy to do, but very difficult to pass. Did you catch my point? So since everything in breast cancer is very well known and it is an easy organ to palpate, both the breast and the armpit, so you must be categorical in your statements. Okay. In a postmenopausal woman with a breast lump of recent onset, it is cancer unless otherwise proven. Good. Go ahead.
General examination, she's ECOG performance status 1, a conscious, cooperative, moderately built and nourished, well-oriented in time, place, person. Patient is febrile and vitals are normal. No pallor or icterus. Lymphadenopathy are present along with the breast examination.
So you can just say general physical examination is non-contributory.
Okay.
Finished. One go. If they ask anything, anyway, it is written in the case sheet. They will look at it.
Okay.
Right.
Local examination of the breast. The patient is examined with arms by the side in all the 3 positions, supine, sitting, and with arms above the head. The symmetry, right breast appears larger than the left breast, and the nipple areolar complex appears to be higher on the right side. And there is a fullness noted in the outer quadrant of the right breast along with the retroalveolar region, and the nipple appears to be retracted partially on the right side. And purely orange appearance is noted around the nipple areolar complex. There is no erythema, ulceration, visible veins, discharge, scars, or sinuses. And on asking the patient to raise the arms above the head and bending forward, there is a symmetrical movement in both the breasts, and there is no puckering noted. There is a mild increase in the nipple retraction on elevation of the arms above the head. And the inframammary crease is normal, and the supraclavicular and infraclavicular areas appear normal, and the ipsilateral arm is normal. And on palpation, the left breast is normal, And on palpation of
Dr. Madhuri, just to interrupt, can you just explain why you asked the patient to bend forward and examine in that position?
sir, because if there is a fixity to the chest wall on the side where there is a lump, the movement between the two breasts, the one with the fixity could lag behind.
Okay, and how do you explain purely orange? Why does it occur?
So purely orange appearance is because of the involvement of the this lymphatics, dermal lymphatics.
Go ahead.
On palpation of the right breast, there is no local rise of temperature tenderness. A single 10 into 10 centimeter lump is palpated predominantly in the outer quadrant and partly extending to the other three quadrants and into the retroareolar region. And with irregular surface, well-defined borders, and is hard in consistency. The skin over the swelling is not pinchable. The lump is mobile within the breast tissue in both horizontal and vertical directions, and on contracting the pectoralis major also the swelling is mobile. There is no nipple discharge. And in right axilla, there is a single discrete 2 into 2 centimeter lymph node palpable in the anterior group, which is mobile, firm, and non-tender. And the supraclavicular region is normal. The systemic
Madhuri, you told that already there is an purity orange, and again you are trying to tell the pinch above the skin is not skin or the swelling is not pinchable. Is it a correct statement or what?
Madhuri, what you clinically examined, what you felt?
The skin involvement is
No. Did you
just summarize to say, this is what my examination finding of the breast and the axilla is?
There is a 10 into 10 centimeter single lump palpable in the outer quadrant of the right breast with purely orange appearance, along with a single mobile axillary lymph node.
So my clinical T stage is, my clinical N stage is, my clinical M stage is for this carcinoma breast.
Yes.
What is your clinical stage now? Breast, as far as the breast is concerned.
Sir, T4B N1, sir.
Coming back to, sorry, Dr. Loknath's question, you mentioned that the skin over the swelling is not pinchable. What do you mean by that when you say the skin over the swelling is not pinchable?
When already
what are
you
you
are telling, other side you are telling purity orange is there, and other side you are telling it is not pinchable.
Two different things, but I just want to understand whether you knew what you are talking about. When you say skin is not pinchable, what are you trying to imply there? Let's say there is no purity orange and the skin is not pinchable. What do you mean by that?
The breast is stretched by the tumor.
Yes, sir.
Am I right?
Yes, sir.
Or
and
you
it's
mean to say
extending
that
into
skin
the
in
subcutaneous planes.
Yes, sir.
Or you mean to say that skin is involved?
No, sir. Skin involvement we can say only if there is a purely orange appearance or if there is ulcer or nodules, sir.
So this statement which you made, the skin is not pinchable, you are meaning to tell, like sir said, that you want to imply that the skin is so stretched over the tumor that
Yes,
the skin is not pinchable.
Yes, sir.
Okay. I don't see any implication of that, whether you want to bring that in specifically. And the picture that you showed of that breast didn't seem like it was non-pinchable to me. I mean, the other doctor who was examined can just come and correct on this. Dr. Santosh, I believe.
Dr. Santosh?
Sir, on examination, there appeared to be a purity orange appearance.
Okay.
And the skin was definitely taut on palpation.
Okay. Okay. Right.
Go ahead.
Okay.
Examination is normal, sir. My provisional diagnosis is carcinoma right breast, C, T4B, N1, and MX.
Can you elaborate what are the like T4A, B, C, D, E?
Yes, sir.
Different components.
Yes, sir. T4A is involvement fixity to the chest wall, sir. T4B is skin involvement, sir. Either there can be a purity orange appearance, skin nodules, or ulceration. T4C is a combined A plus B, sir. That is both chest wall and skin involvement. And T4D is inflammatory breast cancer, sir.
Suppose now the patient has got multiple nodules. So where does subcutaneous nodules? Where does this come into? Which subcategory?
Only if there are only skin nodules, then it is considered as T4B, sir.
Yes, that's what I meant. Multiple nodules also it will come under T4B. What are the components of the chest wall? You told the T4A is a chest wall involvement. So what are the components of the chest wall?
Sir, if it is fixed to the ribs and the intercostal muscle, then only it is considered as T4A, sir. The pectoralis is not included, sir. Whether if it is fixed only to the pectoralis, then it is not included as T4A.
Anything else is there? Okay, go ahead. Go ahead.
Yes. So my provisional diagnosis is clinical carcinoma right breast, clinical T4B N1 MX, sir.
Okay. Sir, Raghunath sir.
What makes you think that the node in the axilla is significant? You have put it as N1. It is significant?
Yes, sir. It's a 2 into 2 centimeter firm lymph node, sir.
Disproportionate to the 10 centimeter mass? Proportionate to the 10 centimeter mass? I just like needling, nothing more than that. Proportionate, disproportionate?
Proportionate.
What do you
proportionate. You think the primary is very big, but the nodal metastasis is very small. N1 you said. That means it is still mobile, solitary node, not more than 3. Am I right?
Yes, sir.
This is a peculiar characteristic of Indian women. The primary is very large, but the nodal metastasis is not very significant, not in consonance with the primary. Okay. Let us say you had such a big colon cancer, or an endometrial cancer, or a cervical cancer, or a throat cancer, or a oral cavity cancer. The number of nodes will be in hundreds. Okay. In breast, in Indian women, for some reason, the number of nodes in the clinically involved nodal disease appears to be smaller than the rest of the primary tumor. This is something very peculiar. Now, what does this tell you? What could this be histologically? Is it behaving well? Is it behaving badly? Any guesses?
Is it a
okay, I'll put it this way. Could this be a HR positive tumor? Could this be a TNBC? Could this be a HER2/neu only positive tumor, or a ERPR HER2/neu positive tumor? Can you make a guess?
Guess.
Hormone receptor positive.
Excellent. So the primary is large, nodal disease is small. Let us say it is TNBC. What will be the presentation like?
The nodal burden would have been more, sir.
Nodal burden is higher. Typically, you will find a supraclavicular node, an apical node, a fixed node, a big bunch of nodes adhering to the axillary vein. Okay, this is the typical presentation for a TNBC. But for an ERPR positive disease, the primary is larger, the nodal disease is smaller. So that means it's a good prognostic tumor. Okay. One, of course, the tumor grew as the woman was watching. That's the only problem which happened. Okay. Good.
And this indirect evidence to say that's a well differentiated tumor. Maybe a grade, the tumor is maybe a very low grade tumor. Yes. Go ahead. Go ahead, Madhuri. What do you want to do now?
Dr. Madhuri, can you just tell me what you mean when you use the term locally advanced breast cancer? What do you understand by the term? It's a term which is commonly used. So
Yes.
what do you understand by the term locally advanced breast cancer? When will you use that term? Will you use that term for this patient?
Yes, sir. Because tumors usually more than T3N1 are considered as locally advanced breast cancers.
Okay, go ahead.
So I would like to go in for diagnosis. I want to do a bilateral mammogram, biopsy, and IHC on the biopsy specimen.
Why do you want to do a biopsy? Just FNAC is sufficient, isn't it? Fine needle aspiration is enough.
Sir, FNAC may not accurately show the invasive component. And for IHC also, it would be better if we do on the biopsy specimen. Right?
What IHC you want to do on the
ERPR,
biopsy? Hormonal receptor status you want to see.
Yes,
So are
sir.
there any studies like where they have done hormonal receptor studies and FNAC of the breast lump?
Not sure.
What sir is asking is, can it be done? Can it not be done?
It can be done if we do a cell block, sir, but the sensitivity, I'm not sure.
No, the thing is, can we do the FNAC fluid staining for ERPR on a slides? Can we do?
Slide, not sure.
The fluid you can take it on the slides. Can you do ERPR on that?
Have you heard of immunocytochemistry?
Yes, sir.
Like immunohistochemistry, you can do immunocytochemistry on cells on a slide. It can be done on board. It can be done on bone marrow aspirates. It can be done on FNAC slide. So it can be done. But like you said, the sensitivity is likely to be lower, and some extra information which you need may not be available on a FNAC. So generally, it is preferable to have a biopsy.
Yes.
Okay. Go ahead.
You wouldn't like to do any other test on this? ERPR, HER2/neu, Ki67 you want to do? Irrelevant. Or any other tests in a 10 centimeter breast lump of any relevance? No relevance in a postmenopausal women. Mark my words, you have already answered partly what Dr. Ganeshan had asked. Prasant had asked. Okay. So you must be careful about answering this question. He asked you to define something. Did he not?
Locally advanced breast cancer.
So, in locally advanced, when you obtain the tumor on a core biopsy, is this sufficient? ERPR, HER2/neu is sufficient. Anything else needs to be done. Do you want to do any fancy stuff?
Are there any new drugs which can use for a locally advanced breast cancer?
Huh?
Are you aware
Locally
of any
advanced breast cancer? Something very fancy we can use. Yesterday also it was reported. There are series of webinars running every day.
What is the latest other modality? What is the treatment other drugs used? Sir has given already a clue that you are not picking up.
Madhuri, neoadjuvant systemic therapy. I'm just telling if it is planned. So what all information we want from the tissue? See, you understood, you told ER, PR, HER2, K. Is there any marker you want to do so that you can offer better? For which subset you want to offer such things?
Let us say it turns out to be, under your definition, triple negative. Any other test you want to do? Or somebody says, can we try some checkpoint inhibitors? Would you like to do any test?
What is that? What is that?
Yeah, you're right, Madhuri.
Please be bold.
PDL1.
Yeah. PDL1 you can do. For a triple negative, can we do something else?
What else? What is the latest thing which is advised for a triple negative?
Atezolizumab.
No. What is the investigation done? What is the other investigation done?
That in a hormone receptor, any other hormone receptor we can do?
Androgen receptor we can.
Excellent. So you can do an AR in addition to ERPR.
ERPR.
Let us say the tumor was not 10 centimeters, but had a nodal disease, which is 10 centimeters. So the woman is unable to close her arm down to her side. Okay. And then you have obtained tissue, and at the same go, in fact, now many hospitals and many good academic centers automatically do it. So you don't have to prompt them. But in an examination, you should be very clear in saying, I will ask for the androgen receptor, and like everybody is prompting you, what is the latest? You must say, I will ask for PDL1 as well. So remember this. Is there any reason to do a mamma print or anything like that in this woman?
It's locally advanced, sir.
Good. So you have already qualified that this disease at this point of time is not amenable to, we will come back to that, some form of treatment. So that sort of information is of no relevance to us. Okay. So I will be restricting to the hormone receptors, 3 hormone receptors,
Just now told you
and the
last for
HER2/neu
androgen receptor.
PDL1. 5 are in. Okay. Excellent. Go ahead. Though you have done a biopsy. So for a moment, let us say it comes as ER positive, PR positive, HER2/neu 2+. Okay. So what shall we do?
Sir, HER2/neu 2+ on IHC we can do a FISH, sir.
Okay.
So on FISH we can do dual probe FISH or the HER2 gene copy number.
Very good.
The HER2/neu gene copy number is more than 4, and if the HER2 CEP17 ratio is more than 2, then it is considered as positive by FISH.
Okay. Right, you did that. So HER2/neu came as 0 or negative by FISH. So she is ER positive, PR positive, 10 centimeters. HER2/neu by FISH is negative, and the PDL1 is going to take some more time, another 10 more days for you to get the report. So what is your treatment plan for this woman?
So I'll go ahead with before starting neoadjuvant chemotherapy, I'll be doing the staging investigation.
Okay.
Staging investigation, either CT, thorax, abdomen, or bone scan, or if affordable, I'll go for FDG PET CT scan. And if it
What
is,
are your chances that you will upgrade this woman to a stage 4 disease, solitary or multiple, for a ER positive disease?
less, sir, because
High, low, moderate, like the British, or you want to choose percentages? About 5%, 10%, 15%, 20%.
So with the hormone positivity, like where all you get expect other sites of disease?
bone mets, sir.
Yes, the bone disease is quite likely when there is a HR receptor is positive. And the other thing, my line got disconnected. Sir was asking about asking for an androgen receptor. What is the incidence of androgen receptor in triple negative breast cancer, Madhuri?
Not sure.
Am I audible? Am I audible to you?
You're audible,
Yeah,
sir.
very much audible, sir.
Not sure, sir, percentage.
It is somewhere between 3 to 4%. It's not that very high. Or maximum it is a 5%. Okay, please proceed. So sir was asking, so what is the chances of like a
So you wanted a PET scan, so you must defend yourself.
Why do you want? Why you are asking a PET scan?
Because it's a locally advanced disease.
Okay.
So
is it for management you are asking? Is it for conservation of breast you are asking? Or is it going to change the stage? What is it based upon what? Is it for the management of the cancer you are asking, or is it for upstaging of the disease you are asking? Or both?
Sir, both, sir, because
So both Lokanatha sir told you it is only 5%.
5%.
So is that justification? Well, it is okay, right? It can be justified. Let us say this tumor is ERPR irrespective what the hormone receptor is HER2 positive. What would be your staging investigation?
Yes, sir. PET CT. I'll go ahead with PET CT, sir.
If it is triple negative,
then there is definitely more chance for detecting metastasis.
how high is the chance for finding disease elsewhere in the body? You are answering Dr. Lokanatha, so you must tell.
Sir is asking what are the chances of like brain mets? Like what are the chances of
brain mets, bone mets, asymptomatic liver mets, lung mets can be picked up by a PET CT scan.
HR2 positive, HR2 negative, HR positive, HR negative, or triple negative. So which subset it is common?
TNBC carries a higher risk of systemic spread at presentation. Agreed. So how high is that? 5, 10, 5 already taken by hormone receptor positive. 10 taken up by HER2 positive. How high can a TNBC go?
20%.
Okay, around 15%. Okay, so 15% of locally advanced TNBC can have a PET CT upgradation of your staging. So when you say, I want this investigation, you must be willing to answer what is the upstaging which is likely to happen over my clinical staging. Did you understand what I said? Okay, let us say we had a stage 1 patient. Okay, or a stage 2 patient.
Yes.
Okay, would you still like to do a PET CT scan? No. Would you like to do a chest X-ray?
Only if the patient is symptomatic, then I will.
Yes, all other investigations are totally irrelevant for a stage 1 breast cancer, especially which is hormone receptor positive. There is absolutely no need of doing an ultrasound abdomen, a chest X-ray, except for the anesthetist satisfaction. Otherwise, there is no need to do any of those investigations whatsoever. 95% of them will be found to be not contributory to your staging procedure. So this is very important to understand when you are presenting breast cancer patients. Okay. Now you are planning to talk to the patient. Before you talk to the patient, let us assume that the PET scan has come back negative, that the HER2 by FISH is negative, that she is ERPR positive, and we are now in the stage of planning the tests. So it's about 5:45 in the evening. What shall we do?
No, sir, just to interfere, sir.
Yeah.
Before going to that, Madhuri, like you are asked for a PL testing, no? When do you say it is a significant and when you say it is a non-significant? So, or otherwise, when it is a significant?
What is positive? What is negative?
When you are asking for investigation, you should interpret, isn't it? You have to answer to the patient. As sir told, patient is in front of you.
Yes, sir.
What do you want to see in your report there when you send for a PDL1?
PDL1, what would you consider as positive?
You want to say percentage?
Percentage.
Or what percentage you want to say?
First, Madhuri, first you have to see which method, which kit you use. So do you know what kit is used in?
What is the methodology you have used?
IHC we use, sir.
Kit, IHC kit. What kit you use?
Ventana.
Which one?
Ventana. Okay.
More than 1% is positive.
Who has told it is more than 1%? Is it more than 1% means what do you mean? Is it 50%, 60%, 70%?
I think you have to, I think all PGs should read about this because these questions will come no matter what tumor you're talking about from now on. I think better for you to be comfortable with the various testing strategies available for PDL1 and the interpretation varies from one test to another. So I think I would suggest that all of you read this and be comfortable with these various scoring systems and various interpretations and the implications, at what percentage you will start what drug in what tumor, because you can get this question no matter what tumor you are presenting in the exam. So this is new thing, and everybody should be aware of these things.
Okay, proceed.
So what's it? Let us sit down and chalk out a plan for her.
Yes, sir. We'll do the organ function test, sir.
Oh, done. Everything is done. All reports have come. 5:30 in the evening. You are exhausted. You have been working from 8 o'clock in the morning. Okay. Whom else do you want to have in your conference room?
We will. I'll counsel the patient for neoadjuvant chemotherapy, sir.
With whom? You are committing neoadjuvant, no?
Yes, sir.
It is neoadjuvant or anterior to what?
Surgery, sir.
Surgeon should be.
The surgeon should be seen.
Yes.
The surgeon should see the woman along with you, and both of you must be comfortable that I told you it is ERPR positive. You all okay? So the surgeon should see the woman along with you. Why? When it is ERPR positive, you particularly want the surgeon to be next to you when you are planning neoadjuvant treatment. Why would you want Madhuri?
Because the response to neoadjuvant chemotherapy varies according to the hormone receptor status.
Very good.
Usually the ERPR positive tumors will have less, comparatively less response compared to TNBC or HER2 positive disease.
Okay.
So if the patient, if the lump is not, if it is increasing in size, then the patient might end up going to surgery.
Will it increase in size? ERPR tumor?
It will.
What percentage may increase in size as you give chemotherapy? You know, there are certain centers which complete all the 8 cycles of treatment pre-operatively.
Yes, sir.
And then,
so what percentage of patients will need to be asked to abandon this treatment?
In other words, what is the response rate when you are starting neoadjuvant chemotherapy? What proportion of patients respond? What proportion of patients are stable? And what proportion of patients actually progress while you are giving chemotherapy? This proportion might vary depending on whether you are treating a triple negative or a HER2 positive tumor or a hormone receptor positive tumor with chemotherapy. So you can tell overall and specifically in this context of a hormone receptor positive tumor.
Not sure about the exact percentages.
So take a guess.
Small number, moderate number. Be British when you don't know the percentage. Okay, be American when you know the actual figures.
Is it 5%, 15%, 20%?
Is it small,
25%?
moderate, or large? Who don't respond?
Who don't respond is
fair number, good number.
Madhuri, when compared to triple negative or HER2, what is hormone? We can tell in that relation also, if it's okay with you.
The response is better, the response is poorer, the response is not appreciable.
Response is less compared to TNBC or HER2 positive disease.
Okay. So when does it peak? So you have given one cycle, some 10% has regressed. You have given second cycle.
The response is more with taxane rather than AC chemotherapy.
No, it's all right. We didn't come to the regimen. So you are one step ahead. What we are asking is by which treatment protocol, by which treatment cycle will the response be maximal, beyond which it won't make any more difference.
Usually till what cycles you want to see the response?
How many cycles would you like to give before the surgeon says I will reassess her?
By and large, is it you want to see after 3 to 4
1 cycle, 2 cycle, 3 cycle, 4 cycle,
6 cycles?
Sir, if it is we usually assess response before every cycle clinically. If it is
That is true. That is true. But by and large, when do you say it is a progressing or a response to your treatment?
after
Every
4
cycle we are assessing. That is true.
cycles, sir.
So when do we send them for a surgical assessment? Can you tell the institute protocol? So when do you send? After what cycle you send them if you're sending?
We usually complete all 8 cycles of chemotherapy before sending the patient.
So you are completing all 8 cycles before you send them.
Yes.
So at 8 cycles, what percentage of patients will show a 75% regression, will show a 50% regression, will show a 25% regression, will show no regression?
Maybe around 20 to 30% will not show any regression, stable.
20 to 30% will not show any regression. So the tumor remains as it is.
Yes.
Am I right?
In hormone positive.
In hormone positive. How many will have 75% regression?
Maybe around 40%.
40% will show 75. So we have finished 65%. 35% left. So they may show less than 75% regression. Will there be any complete responses?
In hormone receptor positive, very less.
Yeah, for a 10 centimeter tumor, complete responses are unlikely. So the maximum you are likely to achieve in this woman is the best guess is, so when you tell the woman, you will say you will completely, the tumor will vanish, the tumor becomes manageable surgically, the tumor will only be biologically diffused. What is the correct statement?
The tumor would be able to, we would be able to manage surgically at the end of neoadjuvant.
What surgery you want to do?
Because it's a locally advanced T4B MRM with preferably MRM, sir.
Why do you want to do MRM? You want to, before going to deciding MRM, anything you would like to see? You have to assess the response, no?
Yes, sir.
So depending on the response, irrespective of the response criteria, all the patients are going for MRM or they want to go breast conservation?
No, sir, they can go for breast conservation also.
Madhuri, I'll be very careful offering breast conservation in a tumor of 10 centimeter size with skin involvement.
Yeah, if the tumor, if the breast is say 40 centimeters in size and the tumor is 10 centimeters, that means if the woman has a sizable breast mass, but the tumor is big enough, but there you can offer. That means there is some breast tissue which can be conserved. But in the picture you have shown of this woman, although what you have drawn seems to be slightly different from the picture you have put. What you have drawn looks like it is a tumor with breast which can be conserved. Am I right?
Big breast. It looks like a big breast.
It looks like a tumor, big tumor, all right, but in a big breast. So if the tumor regresses by 50% also, the breast can still be conserved. Am I right? Wrong?
Yes, sir.
So that's the reason why you need the surgeon to be in on the scene. Okay. Now, what are the features?
So just to differ on this point so that the students are very clear, I think many surgeons do not accept that with this amount of skin involvement and purely orange, that we bring this concept of breast conservation in such a large tumor with the skin involvement, sir. So I think just for the students that this should be kept as a very, I mean, only if the examiner pushes, let them get into this. Otherwise, some people may not like it if they say that
you are unlikely to conserve the breast.
Yes. So I think let it be very clear. It's highly unlikely that you will offer breast conservation.
With PUD orange. You already stated it is T4B, no?
Yes, sir.
Am I right?
Yes, sir.
So if it is T4B, very unlikely that you might conserve the breast. This is what Dr. Prashant is trying to tell you.
Yes.
Okay? Unless, of course, it was a triple negative tumor or a HER2 positive tumor and the response was pretty dramatic. And you can remove that part of the skin which you said was not pinchable. Am I right? This is what you said.
Yes.
The skin was not pinchable. So all that non-pinchable area probably has to go with the breast tumor. That piece of elliptical piece of skin must also be sacrificed. Okay. So that is important to understand. Instead of offering her breast conservation, along with MRM, what else can you offer her for excellent? Let us say you want to have cosmesis.
Reconstruction.
Primary reconstructive.
Reconstruction.
Primary reconstruction. Okay. Now you had done a anterior chemotherapy or neoadjuvant chemotherapy, and then the woman had some, let us for argument's sake take, she has 65% response, and the surgeon wants Madhuri to evaluate and tell whether this woman needs a mastectomy or not. For an argument's sake, let us say that she had a little than more than a moderate response, and she did not have PUD orange, she did not have skin infiltration or skin non-pinchable skin. What is the test you would like to do? We missed that when you presented in your staging investigation. So I am asking that question now.
MRI, sir. MRI, sir.
No, not MRI. Anything else? MRI of the breast? You meant MRI of the breast?
Yes, sir.
Okay, you could do an MRI of the breast. Anything else?
Repeat mammogram before surgery.
Very good. You would do a repeat mammogram. So what are the mammographic features which might preclude, and what are the features on a core biopsy which might preclude a breast conservation?
Multicentric disease, sir.
On the mammogram. Anything else?
Yes.
Would you make
on the histopathology
multicentric disease on a mammogram? What indicates that there could be multicentricity?
What is that?
What feature?
Diffuse calcification. Diffuse
microcalcification.
Microcalcification. Okay, that's fine. But anything on the histopathology of the core biopsy where surgeons are shit scared or they don't like doing breast conservation? Although it's not an absolute contraindication.
The associated DCIS.
Okay, abundant DCIS. Abundant DCIS can also be a contraindication. Also, it's not an absolute contraindication. It can be a contraindication to that, to breast conservation.
Dr. Madhuri, just to put in a more difficult situation, let's say the worst case scenario comes true and you start this patient on whatever your neoadjuvant protocol, and after 3 cycles, she actually has progression of disease. What will you do now?
Send the patient.
The tumor size has increased, her lymph nodes have increased in size. Now what will you do?
We'll send the patient for surgery, sir.
Surgeon says it's not operable, it's already infiltrating the skin, he cannot get a margin, he cannot get a coverage. What will you do?
Maybe RT.
What are the options?
Radiation can be tried, sir.
You can try radiation.
Yes.
What else will you do? Can you change the chemotherapy and see? Whatever you have started, you can change the chemotherapy and see.
So change of the drugs is also one of the options.
I would also suggest that you should always review the histopathology once more. You should not assume that there could be some other component which you missed. Okay, so maybe just go back to the pathologist and ask whether something was missed, that this was a straightforward tumor or there's something else. Okay.
Yes.
You should review the histopathology, see whether some alternate chemotherapy can be tried, and radiation. These are the 3 options. Okay. And discuss with the surgeons whether some reconstruction can be done, because you are desperate. So surgery has to be done. So sometimes surgery is possible if they can bring a flap or something like that to get the cover. Okay. These are the options when you have a totally non-responsive or progressive disease on neoadjuvant chemotherapy. Go on.
There's one more scenario, Madhuri.
Yes.
Now, let us assume that sir is talking only about progression and all. Now there is a good response. So now totally the breast lump is not at all palpable, isn't it?
Yes,
so
sir.
then how do you approach? What is your plan of this is after 8 cycles of chemotherapy.
Yes,
where
sir.
patient is responding, there's no breast mass felt. So what do you want to do next?
Usually, before starting neoadjuvant chemotherapy, because this scenario can happen, usually we can put a radio opaque marker, sir, in the lump site, so that even if the tumor completely disappears, we know where the tumor was, and we can like make sure that entire area is like removed during surgery.
So whether you want to do a surgery or get away with the surgery or only radiotherapy is advised.
No, sir, surgery has to be done.
So local form of the treatment has to be done. In that case, what exact treatment of type of surgery you want to offer? So there is a complete response. Clinical, I'm telling, clinically.
Better to go ahead with MRM, sir.
Okay, okay. So when do you say it is a PCR?
When there is YPT0 and YPN0, sir.
No, can you define? Don't tell the staging, define.
When there is a absence of tumor on the postoperative specimen, no viable tumor on the postoperative specimen.
Very good. Suppose if there is a DCS component is there.
Will it be counted as invasive or not?
No, sir. No, sir.
So, is any new parameters have changed in assessing PCR? Sir is asking. So, if you read older studies, it was PCR, just PCR. Now it is like invasive free. If you read new trials, the Katrina trials, they have defined differently. So, any take on that?
Not sure.
What is different in the endpoints?
Not sure.
Okay. So if you have a response, complete response in breast and complete some little residual disease in axilla, prognostic wise, is anything different? The response, best response in axilla is better, or the best response in breast is better?
Not sure.
The studies are ongoing, so it will be addressed. The few of the endpoints have been changing in the PCR. We should know what is to be seen in a sample to be seen that complete CR is there. So, Lokman sir, you can continue. So, can you hear?
Yes. Okay. Raghunath sir was asking some questions, so we interfered in between. Sir, Raghunath sir.
Yeah, tell me.
You were asking some, we were actually interfering you.
Yeah, I mean, we know that the responses in the ERPR positive tumor is unlikely to be good. Okay, at least with the so-called AC/4 chemotherapy. So in your hospital, if you are going to give 8 cycles all up front, and the tumor shrinkage is less than 50%, what do you do then?
In hormone receptor positive disease, if there is a residual tumor, then we usually don't do anything. There is data only in TNBC and HER2 positive. For
No, don't do means you won't do the surgery, or you do the surgery?
Yes, surgery we will do.
Okay.
We'll go ahead for surgery followed by RT.
Okay.
Good. Then
what is the RT protocol that we use for this patient? Let's say that she had neoadjuvant chemotherapy and MRM.
Yes.
What will you use? Radiation? How much radiation and what fields will you cover?
Chest wall and supraclavicular area.
Okay. Will you cover the internal mammary? You won't cover the
internal mammary also will cover, sir.
So what is the protocol? So you must all be sure about what protocol is followed in your hospital. Okay, be sure of that. Some people cover the internal mammary, some people don't cover the internal mammary, but be sure of whatever you are telling. And what is the dose of radiation used?
It's 45 to 50 grays.
Again, tell what is used in your hospital.
I think
your answer should be complete, no? Like how much you're giving and how many fractions
and how many doses?
Not sure.
That means you are not coordinated with your RT colleague at all. That means you are not seeing the radiotherapy charts. What, Madhuri? How many fractions per day? How much? What is the dose they are giving for the breast? And as Prashant asked, what are the fields they are covered?
Do you need to cover the chest wall?
Yes, sir.
Do you need to cover the axilla?
Axilla, no, sir. If patient undergoes axillary lymph node dissection, then we don't cover axilla.
Okay, let us say you have 18 residual nodes out of 36 nodes removed.
Yes, sir.
Do you cover? Don't you cover?
No, sir.
36 of 36 nodes are positive.
No, sir. Once axillary lymph node dissection is done, then there is no role for.
Good. Okay. So when do you give radiation to the internal mammary chain? Not a very difficult question to answer, Madhuri.
Usually all patients it's included.
Come on.
What are the
specific indication?
drainage
What's the specific indication for an internal mammary chain irradiation? Where should the tumor primary be, in which quadrant of the breast
Inner
to
quadrant.
plan for internal mammary chain irradiation?
Inner quadrants.
Inner quadrants. So upper and lower inner quadrants are the ideal situations to irradiate.
Or if there is evidence on CT scan.
On a CT scan, sometimes even on chest X-ray you can find it. If you are careful enough to read, then you can make out. It's very easy to make out, not at all difficult. In fact, we used to percuss and make out when we had no CT scan. You can percuss and make out, yes, there's a node behind this space. Okay, it's that easy to make out. Well, good enough. So when would you include the supraclavicular or infraclavicular fossa? You include, you don't include?
Include.
So is there a role for nodal radiation? No role for nodal radiation after a mastectomy plus axillary clearance.
Not.
Supposing you could not remove the nodes, they are stuck to the axillary vein.
Then we have to include, sir.
Patient has got a brachial plexopathy. Preoperative upper limb edema. Lymphedema of the upper arm. Are they indications? Not indications. Worsening indications. They will worsen the condition or they will improve the condition? No.
It will worsen the condition.
Worsen the condition. Okay. So what is the latest about irradiating the breast? Standard 25 to 30 fractions of radiation. Same dose in less number of days. Or higher dose in less number of days. 2 fractions a day or a single fraction with higher dose.
Especially now COVID is ongoing. So do you want a multiple?
There are some recommendations, no? How to complete radiation in breast cancer in the advent of COVID.
What do you understand by hypofractionated radiation?
We will reduce the number of fractions but increase the dose per each fraction.
Okay. Is there any trial to show that that is good enough in breast cancer? Because nowadays everybody is talking about hypofractionated and many people are following that to reduce the number of visits to the hospital, right? Because of the COVID. So are there any studies? Is it good enough?
Good, bad, ugly. Is there evidence? No evidence to back up the radiation oncologist. Or he is just shirking his duty and playing on his video games.
We can, good enough, and we can consider hypofractionated artery.
It is good enough. Yes, there is ample evidence to show that hypofractionation is equivalent to the standard dosing regimens in many locations, not just breast, in many locations.
Again, I'll ask you a difficult scenario. Suppose you have done your neoadjuvant and the surgeon has operated. Unfortunately, it turns out that the margin is positive. Let's say the posterior margin is positive. Now what do you do?
That means the pectoral fascia is positive. What shall we do?
Re-surgery if possible.
Very good. So first option is to always try and do re-surgery if possible and see whether they can get a negative margin. Okay. Very good. If they are not able to do that,
RT we
can give RT and you can see whether you can give a boost to that area.
Boost. Boost is the secret of my energy. Sachin Tendulkar says, no? So it is the secret of even the radiation oncologist energy sources. So he'll give a boost. Okay, good enough. Then what's your long-term plan? So you have finished radiation, you have finished entire surgery is over, your chemotherapy is over prior to the surgery. So 3 modalities are over. Now the woman and her husband or the children in US come back and say, what's the prognosis of my mother? What are her chances of staying free from disease at 2 years, at 5 years, or 10 years, at 20 years?
Sir, before that, she's hormone positive, HR positive.
So you will anyway have to consider giving something else, no?
Yes, for how long you want to give? What you want to give, for how long you want to give? What are the drugs you want to give?
You want to give tamoxifen, you want to give aromatase inhibitors.
Switch therapy, or 5 years, 10 years?
5, 10.
Sir, aromatase inhibitor because she's a postmenopausal lady.
Very good.
If she tolerates well for 5 years without any issues, then we can consider for continuing for another 5 years.
When you're giving aromatase inhibitor, let's say you're giving letrozole for 5 years, what are all the precautions you will tell? How will you counsel the patient when you're starting letrozole and you're telling the patient, see, you have to take this tablet for 5 years? How will you counsel this patient? What all will you explain to her?
One thing is bone. We have to take care of the bone strength.
You tell the patient how she has to take care. What side effects has she got to expect when you're starting letrozole? Nothing, no side effects. Nothing will happen when they take letrozole.
No, they can have, sir. The main thing they can experience a lot of muscle and joint pains.
Okay.
Very good. Then what else?
Dangerous one or more morbidity.
What else with the letrozole?
What do you do a baseline test?
DEXA scan will do, sir.
Why?
Because the osteoporosis is a.
Let's say that you have done a DEXA scan for this lady, and it shows some osteopenia. You're going to start her on letrozole. So what will you do?
Sir, we'll start her along with that. We'll give her calcium, vitamin D, and bisphosphonates.
How much calcium? How much vitamin D?
How much bisphosphonate?
How frequently would you like to give, and what bisphosphonate you want to choose? Oral, IV, monthly, 3 monthly, 6 monthly.
IV.
Let us for a moment imagine that she did not have breast cancer. Okay. And she is your neighbor's mother-in-law. And somebody did a DEXA scan because it is being done free on a camp. And she also went and got a executive checkup done by ThyroCare. And the DEXA scan came positive for the lumbar vertebrae and for the neck of the femur. Okay. So what is your advice? So they came and said, here is a doctor, big doctor. She is from Vaidehi, and let us ask her what should be done. The test fellow will not tell you anything. No, he will do the test and throw the result at you. Okay, if you do 10 tests, at least one of them is likely to be abnormal. If you do 20, 2 will be abnormal. If you do 50, at least 5 tests will be abnormal. No, if you do 100, the chances of somebody going scot-free without any test being abnormal is 0. So she also had a DEXA scan done and it is positive. So imagine that she is postmenopausal. Okay. And this lady is also postmenopausal. So you have to counsel her, no? And she has a higher risk with letrozole. or aromatase inhibitor. So let us know, what is your bone plan for her?
I'll start her
What
on.
are the bisphosphonates you use? What are the bisphosphonates you are going to use here?
We can use.
Whether it is Zolodron. Yeah, please go ahead.
We can use zoledronic acid, sir, IV.
What frequency?
How frequently and what is the dose?
4 mg every 6 months, sir.
Okay.
Then any other drug can be used?
Denosumab, sir.
Denosumab.
Like how much? What is the dose?
What dose?
How much?
120.
Dose?
120 milligrams once in?
Once in 3 months.
120. It is not 120. What is the approved?
For osteopenia.
What is
Not
the
for
other strength
treatment
available?
of the metastatic cancer.
Metastasis. Denosumab, what is the other strength is available?
60, sir.
Yeah, it is the 60 mg.
60 milligrams.
Okay.
Okay.
It is given as subcutaneous, isn't it?
Yes, sir.
Can we use
So
any
among-
oral
Yes, sir.
bisphosphonate? Alendronate.
Yes, sir.
Alendron.
We can use. Okay.
See, we were talking about skeletal related side effects, no? Of the two drugs between anastrozole and letrozole, which drug has got more skeletal related events?
Are you aware of any studies comparing anastrozole and letrozole directly?
Bone-related events are more common with early morning joint stiffness of small joints. Is a feature of anastrozole, letrozole, exemestane. Which one?
Not sure, sir.
Okay, right. Just read that up. No problem at all. Okay, good. So you would give her a
For how
bisphosphonate.
long you want to give?
Sir, for 5 years, sir, and if tolerance is good, then I would continue for another 5 years, sir.
Okay.
Madhuri, you are telling that anastrozole...
Instead of bisphosphonate plus aromatase, can't we give her tamoxifen? It will take care of her bone strength also, no?
No, sir. Before going to that, she told that aromatase inhibitors will also extend for 10 years. For 10 years.
Sir, you're not...
Is it only for 5?
Sir Lokna sir, your voice is not very breaking, sir.
Now is it okay? Audible now?
Better, sir. Now it's better.
Okay. Now, Madhuri, you told that aromatase inhibitor, that is say letrozole, you wanted to continue for another 5 years. That means 5 plus 5, 10 years. Are there any studies that extend aromatase inhibitors? Or you want to give only 5 years?
Study is only 5 years.
Then why did you tell 10 years? I want to give another 5 years extra. What is switch therapy?
We can switch AIs to tamoxifen, sir.
What is that study?
Switch from what to what? Tamoxifen to letrozole, letrozole to tamoxifen?
Letrozole to tamoxifen, sir.
Not from tamoxifen to letrozole. Somebody is trying to confuse you.
Which is more important in the beginning? Letrozole should come in the beginning or tamoxifen should come in the beginning?
Sir, for her, letrozole, sir.
For anybody, if you're switching, the letrozole should preferably come in the beginning because the risk of relapse is higher in the first 3 to 4 years. And after that, the risk is lesser. So the more powerful drug should come upfront. Okay, so preferably the letrozole should come upfront and you should switch after that.
Okay.
Yes, sir. Raghunath Rao, sir.
No problem. Okay, go ahead. So you have not told me how you will explain to the family what are her chances of staying disease free for 2, 5, 10, 15, 20 years.
You really want to follow her up for 20 years? Is it really necessary?
No, sir.
No?
The recurrences are more common in the first 2 years.
After 10 years, you won't recur?
In this patient,
Majority actually will start recurring once you stop the anti-estrogen. Okay. So there is now a move to continue it for lifetime. So we will hear about it in the next couple of years. The trials are still going on. So leave it there. Don't worry about it. But the family wants to know as to which brother or which daughter should take care of her. The one in Australia, or the one in Germany, or the third one in US. So they need to take the counsel of their own wives before they can move the mother there. So what are our chances of surviving 2 years, Madhuri? Let us talk first. Good, bad, ugly. Is she likely to cross the 2-year mark?
yes, sir.
So with what certainty? 80%, 90%, 100%?
80%, sir.
80% chance. 5 years? 60%, 80%, 75%?
60%.
60%. Okay. 15 years. 50%, 60%, 55%. Remember your first statement and then calculate. Remember your first statement. The maximum number of relapses are within the first 2 years. You have already stated. So now reduction in the chances of recurrence. Okay.
Yes.
Okay, it will be about 55%. So the same probably will hold true of 15 years. So her chances at 15 to 20 years of dying from a non-malignant cause are higher, lower, the same as general population?
Same, sir.
Hi, she is already diabetic, hypothyroid, hypertensive.
Yes.
So will it be higher, lower, or same? Cancer patients in general will have a higher chance of dying from their disease at 15 years or from that which takes away the general population without a cancer.
It's a non-malignant cause.
Yes, they have a higher chance of dying from a non-malignant cause. By what percentage? 5, 10, 20, 15?
15%.
Huh?
15%.
I could not hear you, Madhuri.
15%, sir.
15%. You are very, very, very ruthless. Okay. 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 It's not so high, but anyway, there is a higher risk that she may die from a non-malignant cause. Okay. At 15 and 20 years. So 62, you said she is? I forgot how much.
No, she's 56.
56.
60.
56, sir.
56. So, okay.
Yes.
So we can predict up to probably 70 years, 65 to 70 years. That's a good prediction. Okay. What are our chances of developing a tumor in the opposite breast and the opposite axilla?
15%, sir.
So how long do you want her to have a mammogram and at what frequency for the opposite breast?
It's an annual mammogram.
For how long?
We usually continue.
Continue for lifetime?
Yes.
She is 56. Remember, she is 56.
Continue for lifetime?
Because she already had it on the right side, so
Yeah. So the left breast mammogram should be for lifetime.
Until she is in a good health, yes, sir.
What do you mean under good health? She'll be in good health in another 6 months.
Madhuri, as the age advances, the incidence of cancer increases. You know, if you start with very 30, 40, it's 1 in 3 digits. When you go up to 80s, no, it is 1 in 6. So as you age, it advances. So with that in mind, how long you want to do the surveillance mammogram for the other breast? It's a surveillance mammogram.
Continue lifelong.
Lifelong. Okay. Right. Excellent. Right. So, what other non-malignant conditions can we anticipate as a result of our treatment? A higher incidence.
Cardiovascular disease.
Which cardiac or vascular or both?
Cardiac mainly.
Cardiac. She's got a right breast tumor, so the radiation oncologist will wash his hands away.
Yes.
So all the risk will be contributed by your chemotherapy and your anti-estrogen therapy. Am I right? Wrong?
Yes, sir.
Right? So what event should she be at a higher risk for?
So my suggestion to you, Dr. Madhuri, and to all the ANPGs is, these are very straightforward questions, and you should be rattling out the answers. Don't give these one-word answers for something like this. Don't say cardiovascular. Then you wait for the examiner to ask something else. That's not the way to answer something like this.
You say straight away, say this is the risk of for myocardial infarction, this is the risk of for stroke, this is the risk of for having a hip fracture. Okay.
She's probably got anthracycline, so she can get secondary leukemia.
Second leukemia from anthracycline use, things like that.
So please rattle out an answer fast.
Don't give them a chance. Okay.
What is the incidence now? Say like the patient has received anthracycline, you told cardiac. So what are the different cardiac side effects and what is the incidence you see?
MI, sir.
Yeah, state 2. Before MI, anything else?
Cardiomyopathy. They can.
Very good.
Yes.
First is anthracycline induced cardiomyopathy. It is irreversible. So you must remember that. And it can be very incipient. That means patients may forget they have ever received a red medicine. Okay. Second, of course, is a myocardial infarction. There's a higher incidence of coronary artery disease in such patients. These two are very good.
So what is the incidence? What is the incidence now? What is the incidence?
Very high, very low, insignificant.
What is? See, you must have seen in your clinical practice, no? Under Vinayak Kamaka, you must have given so many anthracyclines. What is the incidence? How much is the incidence you have seen?
Did you see? Did you not see? You have not seen. That means the incidence is low, high, intermediate?
Low.
Low, very good.
Madhuri, it is said that if we have to classify the patient, whether he has got a diabetes or hypertension. So patient who has got a diabetes and hypertension, the incidence will be 5 to 6%. Suppose if the patient doesn't have these two, the incidence is somewhere between as low as 2 to 2.5%.
Okay.
This is a very standard question.
So this is what you need to tell the patient's family when you treat them. Since you have a risk of hypothyroidism, hypertension and diabetes, you have a slightly higher risk of cardiac problems later in life. Okay. Then they will say, what about cancer? Can I get another cancer? What cancer are you worried about?
Leukemia.
Before leukemia?
Before leukemia, what?
Opposite.
What treatment they have received?
Opposite breast.
Yes.
Opposite breast. Okay, good. Then
treatment related?
Radiation related?
Lymphomas.
Lymphoma or sarcoma?
Sarcoma.
Okay, right, sarcoma. Okay, before an actual leukemia occurs, can anything occur? More commonly than a leukemia?
MDS.
Myelodysplasia.
Yes.
Good. So
Yes,
myelodysplasia is more
good.
common than leukemia. Okay, right? Right, very good. Right then. So You make a note, take a notebook, write down how you presented, what were the questions asked, and you should be very ready with the answers. Okay. So it is important to understand that if you get breast as a long case, it is easy to make a diagnosis, but sometimes can become very difficult to face the questions. So there are two aspects of the presentation. One is, what will you do for this patient, for my patient, my patient. So you keep saying for my patient. Then we keep changing the scenario. So what if the tumor size is less? What if it's a T2 tumor? So what we are trying to get at you is, if what is the difference with the age, the stage, the immunohistochemistry, combinations, and then the treatment approaches. So that is what is likely to be asked in breast. So the factors are the age, the stage, the immunohistochemistry, and of course the treatment choice, whether the breast can be conserved, the breast cannot be conserved. These are the important permutations and combinations. Please remember that if in the early stages of breast cancer, you are being asked what are the tests you would like to do, then you can go for a gene panel, etc., etc. And you should be ready with what is the percentage difference which chemotherapy is going to make for the basic treatment, surgery, hormonal manipulation, without radiation. This is important to understand. So it may be as low as 2%. Okay? If you are giving chemotherapy, the benefit at 5 years, 15 years, 20 years may be as low as just 2%. This is important to remember. Okay? So don't worry about the case presentation. The case presentation is just to get your idea of very quickly to a summary and then participate in the discussion. So the discussion is the most important part in a breast cancer. And be ready, as Dr. Prashant has suggested, to blurt answers. Don't give them a chance to ask a corollary question. Start answering as quickly as possible. All right. Santosh, anything? Who are all the teachers there? Some I know. Vinayak sir has already been very active. Loknath sir, Prashant. Anything, Santosh, you want to tell the students?
No, sir. Thank you so much. And all the questions that were asked from previous session and the present session, I will try to summarize in the comment section.
Okay.
Outside, and if somebody has missed the questions, they can go through the comment section. Okay.
My humble request is, don't log in with your model numbers. AAA 33, AAA 9, AAA 61. We want to know who are the students actually present with your own names. So try to see if you can give a name to your mobile number so that we can identify, or at least in the Zoom, give a name for yourself so that we can identify who all the 81 participants are. So if we take away the student and the examiners, so that should be roughly around 75 participants. So Dr. Santosh and Dr. Vinayak have a right to know who are all the people who have participated, so that the percolation is very abundant. Am I clear? So try to give a name for yourself when you put in your Zoom, etc. Dr. Ravi, Divakar, any more comments? There are some more seniors here, right?
Sir, I think a lot of people. Sir has muted himself, so I cannot make.
Okay. Huh?
Okay then.
Very good.
Vinayak.
Sir,
excellent, Dr. Vinayak. I really appreciate your choice, and I hope the DNB takes a stand that this is how the exam can be done with the local mentors. For example, those who have participated in this meeting itself can be the local examiners. 2 examiners can possibly be called from outside, and you will be soon able to complete the examination. This is what I am planning to recommend to the board of at least DNB, and possibly to the board of governors in the MCI as well. So let us, you should all give it to your own universities. Dr. Vinayak sir can actually give it to his own universities, since the they are also doing the DM course, that we can co-opt for examiners for an online examination and quickly get the students to finish their examination and take their degrees. That would be an ideal situation. And so also from Vaidehi. Sandeep, you want to give any comments? Okay, then. Wish you all the best. And thank you for the opportunity. I would like to thank Prashant and Lokanada for their patience, along with Dr. Vinayak and Madhuri. All the best to you, Madhuri.
Thank you, sir.
Thank you very much, sir. Thank you, sir. Thank you, sir. Pleasure talking to you, and good luck, Madhuri, with all your preparations and your exams.
Okay.
Good job.
Okay. Good luck, everyone.
Don't get rattled. The idea is to rattle you. We want to shake you. So don't get rattled. Be very patient, very steady. No harm in saying I don't know the answer, but it's all right. Okay, good.
Thank you.
Okay, good.
Bye. Bye.
Thank you, sir. And I'll thank this program is done by not just Ramaya or Vede. It's done by with collaboration with Kidva and all the people. I think the names is based upon students' registration, because there is a lot of participation from first year and second year. To identify final year, we have put that AA so that we can identify and pick them. It is only suffix. The whole name has to be along with it. Any questions from students or anything? I think we are one. We can close the session. Shashidhar, anything to add?
No, Vinayak, it was very good actually. No problem. Very nice.
So next week we'll plan some long cases. We'll get back with
Can we do short cases as well?
Yes, sir.
I very often find that they are not tuned to the short cases.
Sir, we have a plan of 4 sessions. I think I'll explain. 2 sessions will be on long case, two long cases.
Okay.
Then 2 sessions on 4 or short cases.
Yes, yes. Short cases are equally important to pass the exam.
Yes, sir. So we'll structure it. Next time we're planning with Manipal and Kidwai.
Excellent.
I think Ma'am is there already. Poonam Patil Ma'am is
there.
Yeah,
I'm here, Vinayak. I'm listening to all the things.
Okay, Poonam.
Good afternoon, sir.
How are you? You didn't talk.
Yeah,
must be having lunch already.
No, not at all, sir. I was just sitting and enjoying this. It was good. The first case also, testicular tumor, was very good.
Excellent then. Bye-bye then.
Yes.
All the best.
Bye, sir. Bye.
Thank you, sir. I'll end the session.
Thank you.
Bye.
And I think next meeting we'll try to do it more structured. This is the thing that. So with that, I'll close the session. Thanks all the faculty from Vaidehi and Kidwai and Rama and Dr. Santosh. So hopefully we'll see more of participation and have a more. The idea is that before the exams, we finish one round of all the cases for students. Thank you.
Thank you.
Good, Vinayak. Very good.
Thank you, ma'am.